Mr. Ramon. Yeah. And I thought Dr. Mary was going to teach us at 2:00. It's a word class, but I thought one of them was like going to.
Yeah.
That's what's gonna happen.
Yeah.
Oh, okay. That's for today, or that was yesterday? Yesterday. But today?
One of the that's the article that was posted. Yes, and answer the questions.
Yeah, that's what it was.
I really like to see if I can answer the question.
Oh, wow.
I mean, I probably wasn't expecting it from that. Yes. Yes. That's very much.
Yeah, man, because some persons are in some person are in the email, Miss Stinger sent an email, and yeah, Miss Prince sent an email.
Great.
You find the question, Nicole? You read the article already?
Yeah.
You never read it. They see the question, but I wonder where the article was. Yeah? I mean, that's called efficiency. Yes, yes, yes.
Even if it's one.
I was wondering, I was thinking about books, but you see that it just for I think so Because when they started,
Oh, you want to know more? I know. You know, these talking their faces. Yes, we did. One of the Sundays, right? Like it went empty. They're disobedient. They're disobedient. They're like you, but they don't like it. They don't have a lot of hyperlink, so it don't make sense to put that one next to the change their mind. Yeah, present from this because there are some documents and videos that link back to this. You get what I'm saying?
But to,
It's the same thing, but you don't have the documents that some of the things are linked to. So pull this down and then let me present from that.
let me stop sharing.
Some of the videos are too large and so. It works. I went test one of them. We're not enough fancy stuff. Let's just see if the video works for argument's sake. So you're opening up from.
Oh, go.
No, go back to community health. Community health. Then, no, not that, back into community health, you went fast.
Oh,
MPH. Then you should see Hecon. And then I think this is, hold on, let me see the date. Right, the very last one should be this one, final.
Oh.
And then let me just check if this is working. So go to the video, which is the third slide, and let's see if it works. Play it, yeah, let me see if it plays.
Yeah.
Let me see if we're hearing. No sound. It's at 100%, so I'm not hearing. Okay, that's what.
To was tabled in Parliament today, but with just 60% of the population said to benefit in the first phase of the program, the opposition continues to make it.
There's another one I want to just test very quickly. Which is that one. There's another video I have on there, but let's go on. This one, let me hear. See if this one plays. Hope I can keep them awake on a Friday evening. That is good.
and Nicole is eating my favorite, but that doesn't put it to sleep.
I have a
No, yeah, quality of life is important. Quality of life is really important, you know. I always say,
So you went join the class as student and tutor.
Yeah, I'm gonna say where you was a
Student and tutor, right there, remember?
You remember? It's just sitting right there. You know who came from Antigua, Leslie Wall, she's here today. She's here on campus because she's a professor for an American university. Just this morning. Yeah, of course, I will find you. You have to keep winning.
I haven't fully comprehended.
Like money,
I'm still like to have people sometimes something solid. No, and then I can set up opening there. Everything all the and I looked at I heard that. Because every decision is never so that's why I'm happy. That's why I sent it as well, just in case. I see it's like coming here, or is it? And then my yellow shirt says. Because it's Friday. Yes. Does this use it uses a microphone or not? No.
multi-directional.
Okay, something another. This room, he picks up, and if something is going wrong, he'll come out. All right, let me then get going. All right, good afternoon, everyone.
Good afternoon.
I am Colette Cunningham Mary. I hope you can see the screen very well. Can you? Yes? Yes. And it is a pleasure to be here. I can't tell the last time I've taught in this classroom. But that is life for you. I usually, if it's the first time teaching a group, I always like very brief introductions. I did ask for a list of the class list. I did ask for the class list and received it. Some faces I recognize, but I usually like to ask you just for the purpose, you've probably done this a lot already in the year, your name, not only for my sake, but for Stanley Laltov, who remembers exactly where I sat 20 odd years ago. Where his baddies, that's where I sat. So I used to sit right there. And I sat right there 20 odd or so years ago, or so, it's really more than 20. Because one, I couldn't see very well, and I found I was easily distracted. So most of my friends are at the back, but I just would get distracted, and I sat there. And his course was one of those that I found very, very interesting. That as well as stats. I'm a little unusual. Most people don't like those two courses. And while I'm here in front of you today, just a little background to me, I'm a physician. Also trained, before I did MPH, I did management studies. So medicine, then I did management studies. And in doing the management studies, I was introduced to things like business economics. In finishing, so they used to have what they call a postgraduate diploma in management studies. And I was in the penultimate year before they introduced what is called the MBA, Master of Business Administration. So in the good old days, anybody going into leadership of any worth, they did the postgraduate management studies diploma. So I was in that group. It was a 3-year part-time, and as I said, I was introduced not only to a little bit of business economics, but also business accounting. Finished it, did fairly well. I was shocked because I'm a medic, but you have to interact with people from other specialties around these management issues. And for the NPH was be a great program to pull that training as well as my training as a physician into more management. So I've done that, and over the years worked at the Ministry of Health. At one time I was in charge of disease surveillance. And again saw Stanley at 2 King Street, where the headquarters were those days. He was then doing a lot of work around healthcare reform. Am I correct? And so this is what we call it, decentralization. Right, so we had moved now into regional health authorities. Has it worked, Stanley? I think there's a big question there. There are pros and there are cons to it. So for those of us who know when it was coming on board and to see it now, what are the strengths? Somebody should do a study like that. In a research project, I think you should do an evaluation, anybody interested in policy, as to whether decentralization has worked for Jamaica. But got involved in disease surveillance. It was mostly infectious, but always like NCDs. And so after 2 years, Professor Figaro was in charge at that time as CMO. I told him I want to do what I really came to do and switch to leading, it was chronic disease and injuries. I don't know who does that, or maybe something like what Dr. Gates does. Yes, switched to that. But along the way came JHLS, Jamaica Health and Lifestyle Survey. I had to interact a lot with Professor Terence Forrest and Professor Rainford Willis. And I took a strategic decision to, when an opportunity arose, to come to UA to strengthen research, with the hope of going back to the ministry in 5 years. And it has now been 23 years. I never ever went back full time because I really do enjoy teaching. So that is me. I work out of this department. I do a lot of work on NCDs, social determinants of health, which includes aspects around things like business, economic management. I have a couple first husband papers. I work closely with health economists when I don't know the answer. They jump in. That's why he's here today. So today is a very, for me, emotional day because I was the first MPH graduate of this program to come back and teach EPIC. So that's my tribute to Prof. Wills. And I think I may be the first of Stanley's students teaching health economics here that he taught. This is my first lecture that I'm doing. I'm a little nervous, don't you see? So he's there backing me up. And so it's really going to be me, myself and him. You'll see him coming from time with some questions to explain a little better than I may be able to. But it's an area of expertise that is needed. So if you finally have an inkling to it, it's an area that I'm sure government or others would want to help to sponsor you to get additional training. You cannot find health economics. The first thing any minister is going to say is how much it costs. Do an analysis on this in terms of making certain decisions. So that's me. Now let's see. I only have about a handful of you in the class. Some of you know, but pretend you don't know me. Go ahead.
Good.
Just who you are in, yes, and where you worked and why you're in this course.
Okay, my name is Hecon Thor.
Yes.
I have worked in the Northeast Regional Health Authority, currently practicing as a GP. While I'm in the program, I've seen in my very few, and by few I mean around 3 years of private practice, a lot of gaps as it relates to healthcare provision in the private sector, and having worked in the public sector as well, those gaps below, and it really has opened my eyes to potential avenues where these gaps can be filled and potential policy changes that someone needs to contribute to the introduction of to see these gaps resolved. So that's what motivated me to pursue this avenue of study.
Are you in the MPH, is general, or you're doing the
General.
Akeem, what you did medicine here?
Yes.
Because I taught you too?
Yes.
Yes, oh my gosh,
Yes.
I'm not so young. Because I'm looking at you and saying that.
Yes, you taught us in the 4th year, but when you led my group's research.
It's me?
Yes,
It's not
you and
me.
Dr.
Jackson?
No, it's Dr. It's Waldron, I think.
No, he would have done fourth year. I would have done understanding research with you in year 3.
Yes.
And then year 5 for final year coming.
Final,
Yes,
right,
yes, yes.
Yes.
Great to see you. I really am pleased to see you.
Marie Roberts.
Yes, Marie.
Roberts, a nurse, employed to the Spanish Town Hospital for over 30 years.
Wow.
And presently the infection control nurse and I'm doing the general research doing in program. Is, as you can see, the redevelopment in Spanish Town. So I realized that as an infection control nurse, I need to broaden my area of work and also to make a positive impact.
Excellent, excellent. So you're there with my classmate, Dr. Wright James. We're trained together. So I'm pleased, and you're probably setting up yourself for some management position, hopefully very soon. Wonderful. And I know you very well, but he doesn't.
Before we married, I'm a medical officer working with the KCA Health Department since 2010. I was working over years. My experience in primary health care has taught me that primary health care is the avenue that we're going to do. So, improve the health of Jamaicans. And in reading, so we were actually working on the doctors in KC, looking at some of the challenges we're having and how to overcome them. And in doing that, I also was able to lead through the WHO document on NCDs and the package of care that was recommended. And then in doing that, I also realized that the ministry also had their own plan. And within that plan, there's the role for persons with MPH to assist in the implementation and seeing it through. And that's where I put.
Yes, you want to be ready.
In my background, in working with primary health care for so long, to be a part of that.
Yes, yes. And I'm sure you're going to also move to that level very soon. They all know that you have done a lot of work in HIV. I have let the secret out. So she has been trained a lot in that area. So she has a lot of expertise in that area. Great to see you again, Nicole. All right. Let me go to the others stand by. We're just doing very quick introductions. Lady that is into communication.
Petra Williams-Rayner. I'm the PR and Communications Manager at the Ministry of Health and Wellness.
Yes.
I am in the general track of the MPH program. I am also a breast cancer survivor, and so that is a part of the motivation for being involved in pursuit of the study. And generally, public health is absolutely essential, and we need as many people who are well trained in the area to support its improvement so that we can affect the kind of outcomes that we want to do. So that is my motivation.
And you know, I'm happy to see you. I told you that long ago,
Yes.
even before this class. Excellent, excellent. That means you should be having some very rich discussions in here, given the diversity of the background. Okay.
Keisha R. Trickling, medical doctor at
Yes.
Georgia Hospital. I did the DM in obstetrics and gynecology. And I'd like to find a lot of management issues and issues between policy and what is actually being done at the hospital. And we have a lot of openings for assistance in quality control and infection control and so forth. And they want us to step up. So I thought this would be a good way for me to be more knowledgeable before taking on any of those roles. I'm doing with management.
Yeah, Keisha, well, I've seen your face, I know, at meetings, but the accent remind me.
I'm from Guyana.
Yes, I was just going to say Guyanese sounding, but I didn't want to make an error. I was saying it's either Belize or Guyana, but there you go. But Stanley, you are Trinidadian, right? No, right, you're Trinidadian.
Spent several years working in Guyana.
Guyana as well, yes. Wonderful, great to have you. Were you trained with Peter Carr?
Peter still teaches you that?
Yes.
Yes.
He's doing good?
Oh, yes.
He's
I
excited.
know. Peter is really a champion. All right, two others, and then I'm going to start. Two other ladies came in. Can you share your names? Why you're doing the program? Just a little bit of a background why you're doing the program.
I'm Hecon.
Mhm.
One of the creators of the hospital.
Mhm.
I'm an oncologist there.
Okay.
I cover the areas of alongside health. I do early complication, early pregnancy complication unit, and from the family clinic. Also for quality assurance. That's, as a gynecologist, I realize that there's a gap there. There's a lot of interaction with clinic so far, so we get a good program to help fill those gaps.
Great. I'm a little surprised that some of the specialists, hospital specialists that are in the group, because a lot of times you don't have hospital specialists. Great. Did you take off the year or you just worked out your schedule? Your schedule. Okay. Wonderful. And I think there are two more because somebody is online. Can you share for me your name?
Yeah.
So where you said you were from? Scientific Research Council? Miss Clive, what's the name of your head? Okay, okay. All right. Wonderful. Great to have you. Have you thought of your research project title yet? Oh, okay. So you're going to get granular like, okay, okay. All right. And the person online, we normally communicate with that person or they just listen?
Yes,
I can hear
please.
you. Go ahead, please.
Hi, good afternoon. Unfortunately, I'm online because I cannot be physically, I'm not physically
That's
able
okay.
to sit up, be present. I'm Vanetta Johnson Hamilton. I'm a registered nurse midwife, mental health officer. I am a school nurse and I am here because there is a gap in the Ministry of Education. And when I'm done with this program, I intend to present my CV and a draft job description for that position. So in essence, creating
For
one.
what position?
Create a position for school nurses.
Okay. Well, you're going to be overqualified.
No, it would be
Don't answer me.
management.
Don't answer me.
no.
Great to have you. Great
Thank
to have you. I mean, you know, what pillars of development, Stanley? Health, education, and what's the other one? Health, education, and over by economics, isn't it? Aren't those some of the pillars of development? I'm trying to remember.
Housing.
Yeah, but the biggies, as far as I remember, health, education, and I think I call it economics, but economics is not necessarily financing, but it's all encompassed. So, you know, and especially the way we do a lot in public health nowadays, there's a lot of integration. I hear the Minister of Health talking about the sugar sweetened beverage thing recently. And Petra knows that you're going to need a message, communication strategy. So it's not just going to be, there's a concept of health in all policies. So it's not just going to be strictly in a Ministry of Health that we are able to execute some of the programs that we want for the overall betterment of health for our countries, you know? So I'm going to move in. The lecture is an easy one, I think. There's a lot of repeating, and I teach that way for reinforcement. So you will see some things mentioned earlier, and then you'll see them come back again. And every time they come back again in a different shape or form, we're able to pick up what a student just didn't get that first time. So it's not that I'm stupid and don't realize that I showed it before. It's really intentional at times. So the title, Cost, Benefits, and Economic Evaluation in Healthcare. And as I say, Dr. Lalta is not only here as a mentor and so on, but he's also here as a student. So he may ask some questions of me and I may ask of him. Watch this video. I always try to mix the way I teach
because I do recognize that we are all different types of learners. Some people like to read, but some people think stick a bit more. As you watch this video, it's not for entertainment only. So you're going to see something about the vaccine rollout for Jamaica. So we're putting ourselves back into 2020 when the vaccine was rolled out. And this clip is about, I think it's about 3 or so minutes. Make a note of what I want you to answer. How the government would have evaluated the economic cost of this intervention. So watch carefully, make your notes whichever way, and we have a little discussion, okay? Here we go. Let's hope it all works now.
Up first this evening, $3 billion. This is what it will cost the government to roll out phase 1 of the national COVID-19 vaccination program. The document outlining how the funds will be used was tabled in Parliament today. But with just 16% of the population set to benefit in the first phase of the program, the opposition continues to make a case for more Jamaicans to be immunized.
All right, let me just stop a second. Is it that
The Ministry of Health calls it the National COVID-19 Deployment and Vaccination Interim Plan 2021. Health Minister Dr. Christopher Tufton says the foundation is being laid.
Hold on. So we need to mute where?
Just scroll up to the top of the screen.
All
That
right.
green area, the person hover there, and then press mute.
And then press mute here. Mute here.
Just drop down menu, yeah, right.
Hold on.
But then the mic is.
So Sebastian, can you hear? What can I do? Sebastian? Just this? Join, but it's not giving me mute as an option. It's telling me about join.
So there's a microphone at the
the
podium.
desktop mute.
You can mute the
So let me go
microphone.
escape. Hold
Yes.
on, Sebastian, I'm hearing you. But let me come out of it. Can I come out of this? Down here?
Give you the option to mute it.
Ah, that looks like it. That may be it. Let's try again, okay? Says mute audio. I hope I got it right. You see the technology? So enter. Let's go back here. All right, so let's go back up, page up. Fancy technology.
Up first this evening, $3 billion. This is what it will cost the government to roll out phase 1 of the national COVID-19 vaccination program. The document outlining how the funds will be used was tabled in Parliament today. But with just 16% of the population set to benefit in the first phase of the program, the opposition continues to make a case for more Jamaicans to be immunized.
The Ministry of Health calls it the National COVID-19 Deployment and Vaccination Interim Plan 2021. Health Minister Dr. Christopher Tufton says the foundation is being laid ahead of the April rollout of the immunizations. In addition to the National Vaccine Commission, which will provide technical oversight, a National Coordinating Committee has also been established. The country is expected to receive over 900,000 doses of the vaccine through the COVAX facility. The first batch will be delivered on April 21, the second July 21, and the third December 21. At the end of the first phase of the program, it is hoped that over 400,000 persons, or 16% of the population, will be vaccinated. But for the opposition, this is not good enough.
I think that is unsatisfactory. We must aim significantly higher than that. Jamaica, in my opinion, should do its utmost to source sufficient doses to immunize our population this year at a level that will achieve herd immunity.
We are faced with a very practical scenario, and that is that you can't access what is not available. And that is the real challenge that we face, and I say this respectfully. I mean, it's one thing to say we need to achieve 60%, to get to herd immunity. But if the supplies are just not there, they're just not there.
Select health centers in each parish will be designated vaccination sites. Sites will also be established at the University Hospital of the West Indies, the National Chest Hospital, and the Cornwall Regional Hospital, among others, for frontline workers. The minister says the first phase of the program will cost the government $3 billion. $81 million has been earmarked for a consultancy firm to develop and implement a communication plan, $20 million for vaccination training, $240 million for the hiring of temporary staff, and $37.5 million for overtime and other benefits. Phase 2 of the program will begin in 2022. According to Dr. Tufton, 16% of the population will be targeted.
This phase may see the vaccine becoming a part of routine immunization schedules and procurements will be absorbed into the regular budget for immunization. This will have to be expanded based on demand and availability of funds. So there is still some amount of flexibility which has to be exercised based on what we learn as we go along.
Persons will require 2 doses of the vaccine. The Ministry of Health says mechanisms have been put in place to remind patients about the second doses.
All right. Are you quiet? Are you thinking it through? Hold on. When it is blue, is it on?
Yeah, we're hearing you.
Yes, when blue is on.
Sure. Sebastian? Gone to, okay, let me just close this. Do I click here? Yes. So, how would the government have evaluated the economic cost? Let me hear some responses. Some of it, they kind of gave you a hint with the spend. Anything else? Am I okay now? Yeah. So if I do this, I'm not surprised with things like this, you know. Come on, guys. Don't sit back at the scope of it. How many people trying to reach?
Well, I recognize that.
The vaccine. All right, let's start with people. Right. I tried the 4 important W's. When, what, where, what conditions they have. Yes. Here, when you need to get to them. You recall what happened during the pandemic? It didn't start off with my age getting sick. Do you see how the epidemiology is? It's going to come up in the rest of the lecture. But those are some key words. You might have done some descriptive technique. Who, what, when, where. Is it all across the island? Or we're going to start certain places? Anything else about the who? Maybe the age groups, as we say. Do you start with the babies first? Is it something affecting men more than women? Maybe in this situation we didn't see that much of a gender or sex difference. So it didn't matter. Okay? Where you lived, as I said, the condition that persons had. Because some persons needed it faster than others. And it didn't mean that they were ill. In order for our economies to keep going, some people have to be at work, like a prime minister. So if you remember, the first day was given out, all the big wigs like Stanley got first, and I had to wait months. They lined it up, GG, prime members of parliament, whether opposition or not, governor general. Yeah, because these are persons that have to take certain decisions. Frontline, my daughter, I remember she got on the first day, she was like, in hospitals, and it's shown at the time. They needed her badly. She was an intern and she didn't have a day's break. Bam, finish her exams out there because of manpower. So we talk about the human. You are going on to say some other. Right. I was saying the entire scope of it, like how many vaccines and the cost of the vaccines, whether we're gonna need 1 or 2 doses of the vaccine, and if there's a financial cost. Vaccine? Exactly. Some might have been cheaper than others. Some needed 2 versus 1 dose. Some made it easier to access because it's nearer produced in America versus produced in India, for argument's sake. Anything else? The efficacy of it tied into the cost. Anybody? I don't want you to give them all the answers. No. Anybody has anything else? Anything else you can think of that they would have had to think about? Yes. And not only can you get it, but over time can you get it. There's something else that I expected, especially my nurses who deal with vaccinations, to tell me.
Storage and cold chain.
Yes. Remember, there were some that needed a deep freeze of X, and it was, I think that was it, Pfizer. Needed the minus whatever fridge versus AstraZeneca, which you didn't need. And so the chain, the cold chain, those are things that they have to think. Maybe I get the one that don't need the cold chain, but does it work as well? And that's where now they have been asking people like scanning. We're not even going to use these fancy terms when we talk about data, cost, and effectiveness. Those are some of the things that we have played into. Anything else anybody has? I'm going to look at my notes so we can move on. See if I see anything else here. So cold chain, the disease training, which again has to do with human resources. Yes. And then you have to not only hire the worker, but what category. You can't pay me the same thing that you pay standard. When people wanted today, getting back. No, but I saw that 8 to 1 million was yeah, but what was the consulting firm for? Was it the marketing program? Or was it a consultant? Technical person like a medic, you know? They are thinking, oh, what? And I think a consultant firm might have had to do with marketing. You get what I'm saying? So, guys, I just want you to get a sense that there are many different things. The other thing is what I would call an intangible acceptability. They have to consider that. Do we bring this thing in? Are people going to want to take it or not? And as you all know, over time, there were some unexpected things that came about. Everybody thought vaccine from everybody went down and get it. So to the very physicians, nurses, other health workers said no, because you have to understand those things that belief systems, you know, acceptability, cultural norms, as you think about it. All right, so we're gonna move on. So this is where I want to take you for the rest of this very brief lecture. We're going to go through health resources. You should be able to list. We're going to review criteria used to help prioritize health programs. Why do we do economic evaluation? Gonna go through that, including showing you a little video. I found a really nice video on it. You should be able to explain in very basic terms differences in measurements of cost versus outcomes and benefits. And then also be able to compare, discuss the use. When do I use one versus the other? Do I use both or 3? Is there a situation where this one just cannot be used? If this is the research question I want to ask, the economic, you know, the research methodology question for economic evaluation in a particular scenario. As a matter of fact, I would want you, we are now into what, March? Right now you have your research done. I would
You never know. Yeah. I want you to think about that. Okay, so we're moving on. So here are examples of health resources. We mentioned them just a while ago. Things like human scales, the infrastructure. We didn't talk about that just a while ago with the vaccine. Right? You may need to transport people. As simple as that. You may need to have some sort of admin mechanism in place to pay those sorts of systems. All right? With the vaccine, I recall giving them in this very room. They were allergic. Yes, right in that room. So, but it is not as simple as a lot of people economic evaluation. Money, the time as well. Very, very important because time has value. Reasons for the choices made. You hear you're seeing, you have to consider what does the government have? What does that individual have? Is it something that government does? Or does it have to be shared? Or should that be whatever intervention it is? You have to look at the demand as well, right? Depending on the services, depending on the everything on the profile of your population. That makes sense. And you have to recognize it's not satisfied everyone. When you work, especially there's always going to be somebody and recognize it can't satisfy everyone. So, although we recognize that, choices priority setting involves what? Opportunity cost. So what do? What are the alternatives that you are going to have to give up to come with resources for X or for Y? And we are all economists because we make decisions like this in our daily lives. You are here in this class.
Hello? Hello? Professor? Hello, Professor? Hello, Professor?
And so Stanley said, Colette, put this up. Now, before we explain it, anybody can figure out what this is saying? Can you hear me?
Good day, Professor.
I'm trying to walk up and down. I must stay here.
Oh, all right, I'm going to do that. That's not my way of teaching. And it's hard with the rain. Yes, I'll try my best. What do you understand by this diagram? Anybody? Say that again. You agree, Stanley? You agree? Anybody else has any thoughts on it? I don't know your name, sir. Christopher. All right. I don't want to spend too much. Let me just see. Christopher Knight. Hines. You wanted to say something? Physician, where are you from? Urology. Wow, what a nice mix in this class. And when I looked at it, I thought this was your dollar axis. It's not your dollar axis. What is this axis, Stanley?
So we want to show the comparison between if you spend all the money on dialysis, get all of it. Zero money.
Zero money.
Right.
Yeah, so this is a dollar value.
Then this one was zero dollar value.
So both of them are dollar values. So when I looked at this, I thought to spend on dialysis is so much more than spending on immunization. That's what I thought when I looked at it initially. But if you spend all on immunization, you won't have it. So I thought that this could have been interpreted in many different ways. That's why I threw the question back to you. So you see, so it would have been good to correct our labels on our axis to really direct where. But that's how I was interpreting this diagram that I got from Stanley. So let me go on. The crucial line. Whoops. Finite resources is pretty much what you were trying to say. It's a story of our life. We're all economists. So let's move on. So first of two slides, how are resource choices decisions made? And what this is, these two slides are going to show you the context in which sometimes the decisions are made. So if you're looking at, say, our health facilities, you may find that cases are selected based on what the doctor say. This is how you must spend it, right? Or who can get, who should not get. But I would also hasten to say that in my years as a physician, the constituency that you're in makes a difference. When I send my students out, I tell them that all the while. I remember sending them to some real inner city communities that are always having crime. And when you go into some of those health centers, beautiful, flat screen, TV, whatever, it's because of who's in charge of that constituency. No one will steal the flat screen. Oh, I don't want you to come back and call me. No one is going to steal that flat screen TV. So it's not always a healthcare worker. It's really where power relies at times as well, whether it's a healthcare worker or not. So you may find that the cases may be selected in facilities and resources apportioned in a particular way. You see it a lot depending on also the specialty of the person in charge. So you know a surgeon will look out for surgical things. A nurse will look out for things around nursing. Lab people will have that eye for lab. In the private healthcare market, who gets care depends on who has the ability to pay. That is what drove me out of being in full-time private practice. I was working in inner city And one day it hit me. I was in Olympic Gardens area, and then I went to Penwood, if you know where those areas are. And I was seeing patients at a volunteer clinic for a church, Penwood Seventh-day Adventist. And one day it hit me. If I stay in private practice, the majority of these people would never be able to see me. And I thought, what can I do that will have an impact on across the society? And that's how I got into public health. So really, in that private market, you're looking at your profit, margin a lot more. Even though many times people can get assistance through things like health insurance, and that's now where policy decisions around that are very important. Okay? Who can pay, who can get treated, type of work they're involved in, whether the insurance is private or it's public. And Stanley has been working on that for years. You're still working on it, Stanley? Whether government must roll out insurance for the population, health insurance for the population, or should it be left only to those in private? I think Stanley, in 20 years, he'll still be working on that. The second of these two slides, if you look in the public health facilities now, sometimes in those decisions, these are things that are implicit, You have a long waiting list. So in the end, some people don't seek care. Or you may be in there with them as a health worker. But because of the long waiting list, what you tell them to do? See me privately. You aren't gonna get that fibroid taken care of in 3 years, but it's the same me. You can check me outside. Deflection. Sometimes the choices, the decisions are made because you have to cut back staff, services, hours of business. What's going to happen because we're losing some staff that used to take care of the eye? You might have to cut back on that. You get a longer waiting time, or you might not be able to offer it at all. Sometimes you have dilution. You have to ration care. Maybe you would have gone all the way up to seeing a specialist. Maybe you would have given a particular drug for the condition, but you choose generic, which kind of go and do it, but it don't take care of some of the side effects. So the quality may not be the very, very best you could, but it's still not too bad. If it was 3 different drugs for your HIV, maybe you give them the regime that is the one using 2, as you consider how you allocate the resources. Unfortunately, the last one sometimes comes up where you have to just say, you're just not ill enough. Just not ill enough to get in for this care. So we're going to segue into the criteria for prioritizing programs. And in prioritizing the programs, most, especially at a government level, will want to do the greatest good for the greatest number of persons. And that is the biggest difference between primary care and what I call secondary, tertiary care, hospital care. Primary care people, we are big picture people. Why try to treat and pour all the money into dialyzing everybody that has kidney disease? Why? They're at almost the end stage of this disease. It's very better to help the babies. Those are the questions we ask. And you get that sort of problem. But that's what you find governments will want to do, the greatest good for the greatest number of persons. And so for a lot of countries, primary care is being pushed. Even though I would still say in a place like America, they tend to be more sort of reactive. They are very good at secondary, or I'd say tertiary care, sorting out when you have a problem rather than a big preventive care push. You may prioritize the programs based on the things we talked about earlier, when we saw the video, age and sex, what are the health status of the persons like mothers and children, what we call more maybe marginalized, more vulnerable groups. We think of the role they play in society, the elderly, etc. Should you be looking at the men because the men are the breadwinners, etc. Sometimes you look at the condition itself. Again, you'd have seen with the video and the discussions we had. Do you prioritize acute and fatal conditions? That's what happened when we had Ebola on the horizon. That's what happened when we had Chick-V. Everybody remembers Chick-V? That came through the Caribbean. What did it cause? It caused a lot of persons to have a paralysis. They couldn't go to work. They just couldn't move. I remember at my church, you didn't have enough people to throw tide. It's true, Stanley. You didn't have enough people to come to church to throw tithe or offering. So the programs around feeding the poor people suffered because people weren't there. And that's why governments threw its resources, or governments around trying to help with treatment and management of conditions like that. Because you need your population to be working. So acute and fatal conditions would definitely have a priority over chronic and non-fatal. And I think that's the reason why the NCDs have continued to rear their heads and cause premature mortality in our countries. Because as soon as another outbreak with an infectious disease that could kill people comes, everything is dropped, and the chronic disease programs tend to have to wait, and then they start them back up again. Melissa, look at Melissa coming through Jamaica. Yes, people went out there and were treated, but they were treating the emergencies. So yes, if you had diabetes, but you are now having a coma or at risk for something like a limb amputation. Get what I'm saying, guys? And the program gets halted, disrupted, right? The other thing is, criteria, you should be using evidence-based medicine to choose effective and ineffective treatments. You should be using that. And that is going to segue into the value of economic evaluation. This is not done enough. It's not done enough doing the various economic evaluations to assess, is this thing really effective? It's natural for human beings. You came in and you saw something happening, you just want to continue it. You don't want to offend your boss or offend the minister or offend the professor that has started this program. But the truth is, what you might have been doing, they have been effective at one stage, but not any longer. And a lot of times we use economic evaluations to assess this. So we want to see if the health benefits are greater than the cost. We want value for money. So who should decide? Not just the people that are in the healthcare market, not just the health professionals. Who should decide which is the best treatment? Tell me someone. Patient alone? Patient alone? Doc from VJ8, patient alone should decide? Yeah? No. You really need a team approach. And it takes time to get people together. It takes time to take that decision. So you'll never satisfy everybody, but you really should have that approach. And I agree with you. Patients are important. In our health systems, we still are top down in our approach. Very rarely do we take the perspective of the patients, which sometimes will come through like their political representative. Oh, will come through their political representatives, right? But you need a mixed group of persons. What are some of those essential things that are needed? What what Stanley likes to call that essential package of services. So I have another video for you. Let me start to play it quickly so you hear it before the rain comes down again. And I will need to mute. Hey, Sebastian, I didn't put him on the mic. Right, you really want to balance that your costs don't outweigh your benefits or the outcomes of interest to you, whether it's effectiveness, utility, benefit. It's a balancing act, but you really don't want that it is much more costly than of benefit in some or of being beneficial. So here is a little grid that Stanley created. And where would we like to be at number? What's the best position? Number
one.
Number one. Yes. When you think of when you make those choices, it could fit in any one of these. Low cost, great outcome, more. A whole heap of cost, and that happens sometimes. But at least you have a good outcome, but you don't want the outcome to be worse, which could happen. Number 4 is the worst place to be. A ton of money and nothing happening. Versus number 3, costs a little less, but you're having less of the outcome. That's where the challenge is to find the right spot where you get this. But it's not always feasible in health. That you have to recognize. It's not always feasible in health. And sometimes the outcome can be an intangible satisfaction, political allegiance, get voted back into power. And these are things you cannot escape. So I've been in committees at the ministry where you have to select who gets help for their care. Compassionate care program. Somebody with a stage 4 cancer. Should the ministry help that person to get this very expensive treatment? People say, what's the value of that life? What's the value of that life to that person's family? It's a big deal. And they may call a call-in program and so on. And maybe they're on the program every day. And after a while, the minister may say to the committee, let's try and help this person. What is my mother? Oh, she did this for me and so and so. You get what I'm saying? Yet there may be others that it's a cheaper thing and you should really give them. But life is not that straightforward. So don't always think that this is the decision that is always taken. It's not always so. Measuring costs and outcome benefits. So in the video, you would have seen they spoke about direct costs, indirect costs, intangibles. Are all of you familiar with this? And if everybody did accounts, that's where I learned it. So we have to go over it. So those of you that understand it, bear with us. So as was said in the video went fairly quickly. It's a cost that can be attributable to something specific, a procedure, some cost object, service, right? Some product. We call that direct cost. Am I right, Stanley? I don't know if I'm right. You have to tell me. It's there. So you can see some examples there as from the cost side of it. From the outcome benefit side, directly, it can be lives gained, affected positively. You heard about quality of life and all of those sorts of things, right? Treatment costs avoided or averted for sick persons. Then you have the indirect where it's not so easy to put the cost on that one item. And interestingly in the video, they mentioned transport as a direct cost. See, I was paying attention, Teach. So it depends on what you're analyzing and for what purpose, because sometimes you can get the direct cost of transportation. But if the ambulance is carrying people for various things, can you say that that transportation cost is just for, say, renal dialysis? If 2 people are in there, so somebody may say it's more of an indirect cost. So I just want you to know it's not always black and white. It's not always black and white. And that's why when we do research or we're making decisions, sometimes you have to consult. Where would you place this cost? So for the family, or birthdays lost, maybe home support, those are some indirect costs as examples. Look at outcomes and benefits, right? What about other costs saved? Costs saved from what? Let me see if I can give a good example here for you. Avoiding like what? Wages lost? Would that be an indirect? Wages lost? Take time off from work. Yeah. So you can look at it as an indirect cost. And then you have the intangibles, the things that you can't touch and feel. Pain, stress, grief as a cost versus promotion as a benefit, satisfaction, etc. So the 4 methods were presented to you, but as I say, this is a deeper dive. We're going to go through each of them. So cost minimization compares the programs with different costs, but a similar outcome. And the paper for discussion, you all have it yet in your hand? Everybody has it. Compared, so you choose a program and you're checking out which consumes or requires the least resources. So here is an example that Stanley worked out for us. The total cost is different for the different program, program A and program B. 1,000 for one, 1,500 for the other. You want to save 100 lives. So the cost per life saved, am I correct, is 1,000 here over 100 for program A, but the cost for program B was 1,500, but you still want to save 100 lives. So it's 15 per life saved. So what you're going to choose? Which one are we going to choose? Program A. Program A. This is cost minimization. Cost effectiveness analysis is a little different. So remember, I don't know if you remember the video where they're looking at the different programs to see which one to choose based on the particular health outcome. How much change in the cost you had, and also looking at how much change you had in terms of benefit, gain. So here, for example, you could look at how many life years gained. And I'm going to show you in an example now. I put different here because in the video they had same outcome, but it wasn't quite the same outcome that they showed in the video. Because one was showing you cost per life, per oh gosh, just you want the life gain and try to remember the people has. Just life years gain. So the ratio worked out slightly different for both of them. So I would agree that it's a different outcome based on in the video, the narrator said same, but really what he showed you was a slightly different outcome. So let's look here, for example. Pay attention for me. Hope you can see it. Cost for program A, 1,000. Everybody with me? 100 lives saved, each living 5 more years. So how many? So 500 life years were gained. Does that make sense to you mathematically? Everybody, wake up, stay with me. So if you look at the cost, which is the 1,000, per outcome, the outcome of the 500 life years gain, it works out to $2 per life year gain. Everybody with me there? Let's look at intervention B, but it costs more. 1,500, again 100 life years, life saved, but each of these lives living for 10 more years. So 1,000 life years gained. Do you see that? Therefore, what is the cost per outcome? So we put the cost over the outcome, and what is the gain? $1.50 per life year gain. Now, which one should we choose? We're going to choose the one with less cost per life year gain, which would be B, cost effectiveness analysis. Any questions so far? Everybody still with me, including online if she's still here. Cost utility analysis. We're assessing competing programs with different costs and different outcomes. Saw that in the video. That outcome measurement has something to do around utility, quality of life gain, and it can be measured in different ways, the physical, psychological, and social. And then they introduced in the video various metrics that could be used. The one in the video talked about quality of life, as well as what? See if you remember. What was the other thing they used? What did they quality use? And you saw we had the graph with it. Yes, yes, yes. How many years added on? But as well, the quality of the life, because sometimes you can add on years, but you're not living a better quality of life. And so that sort of combined measure, which is a utility measure, quality, was explained. And there are others. We won't go into them today. Disability adjusted life years, European quality of life, 5 dimensions, which Stanley is going to touch on a little for me, because it's not one that I have used. Health life years per dollar spent. The economists go to town with these fancy things. They raise these names, and those of us who don't understand economics open our eyes and we'll drop our mouth in awe. And here is a diagram that is to try and just show you. Anybody understands the diagram? Let's look at this. Quality of life, health-related quality of life. You're seeing here on your y-axis, and what's on your x? Length of life. So remember, we talked about the combination, and pretty much what this is showing, what it in summary is this showing, that with treatment, I remember by the time you're getting here, you're doing your comparison. That's what the economic evaluation is. Should I do this versus that? So it's showing you that there are qualities gained when you have the treatment. Okay? So Stanley, what is this? He's going to tell you now about this EuroQual.
This is one of the measures of quality of life year gain along with length of life. When you treat someone, after the treatment, you usually might ask them, well, how do you feel? That is to look at your quality of life. And what the EQ5D is measuring is looking at 5 dimensions and 5 different levels of attainment. And that's what we call 5-5-5. So we can ask you these questions about your health issues at the end of the treatment. What is your mobility going to look like? And we have measures for that. And you look after yourself, self-care, bath and dress yourself. And you have your usual activities without interruption, without any kind of delays, etc. And to do that, are you in pain or discomfort after the treatment? And are you anxious and depressed? And we have a scale for measuring that. If you have no problem, then you call that level 1. Some problem, moderate problem, and extreme problems. So when you're asking people, how are you, make an assessment, how are you in relation to mobility? They will say, well, probably I have slight problems. Or I have extreme problems, you have to be sick, or you have to be in a chair, or you have to be, or you're very bedridden. Same thing you can ask them about self-care and the rating where they can. And you put all of that together. If you get 1, 1, 1, 1, 1 all the way down, extremely good. You are very, very good.
So the lower the value, the better it is.
If you get 1, it means you have no mobility problems.
No.
1, you can look after yourself completely. Get 1 over here, get 1 over here, get 1 over here. You are completely healthy. And the lowest you can get is over here. But if you have extreme problems with walking,
lowest.
Yes, the lowest will be fine.
Right.
5 year already bad news. The worst situation. Because 5 to be in mobility, you're completely bedridden.
So Stanley, with Euroqual, the lower the score, the better it is.
Yeah.
So the point really is that as you think through economic evaluations going forward in your work or your research, you have to know the tool. Because some tools may have scores that are high, whereas Euroqual, the lower it is, the better it is. You have to study the different tools. And I'm assuming to Stanley that certain illnesses lend themselves more to using certain tools over others. You get it? So it's a whole science with all of this economic evaluation.
So quality of life and all of them ask about really 2 or 3 dimensions: your physical, your psychological, emotional.
Right.
Some of them also relate to your social functioning, which is where your study and work and your leisure activities, etc., are going to come in. Can you go to church without problem? Can you go shopping and these kinds of things will be what you call the social functioning. That's part of it that is picked up. And so to measure the dimensions of health in order to get an idea, how are you in relation to these?
I actually think that we could do something on the class and see where the class is.
I actually wanted to
I'm
ask
sure some of you
Doc.
are thinking right now. Am I right, Doc?
I
I'm
actually
teasing
wanted
you.
to ask Doc.
All
if-
right. So back to the example that we
Well-
use for cost minimization, cost effectiveness analysis, and now cost utility analysis. So if you look here, same cost, total cost per program, we have 1,000, 1,500 per program. 100 lives saved, each life 5 years. So 500 life years gained, but let us say the assumption was that was 50% quality of life. Do remember that the quality of life moves from what? 0 to 1. So if it's 50%, it is 0.5. Ah, my class is still with me, sir. So only 250 quality years gained. Everybody gets that? These are simplistic, you know. They do get more complicated in real world. So the cost per outcome here would be $4 per quality life year. Okay? Agree? Yeah. Let's look at intervention B as an example. 100 lives saved, just as we have been talking about. But each of these lives, what? 10 years, they live for 10 years. So 100 life years gained, but we're now putting in the quality of life, and let us say it is at 20%. So we get 200 quality years gained. Do you see how we get the 200? I don't want to leave anybody behind. Some face is not looking right. How you get the 200? 100 times the 0.2. Sorry, 1,000. 1,000 by the 0.2. Everybody with me? Some eyes looking like they're understanding now. I don't want to leave you behind. Okay. And therefore, then we work out the cost per outcome, which is $7.50 per quality life. $7.50 per quality life year. So which one are we choosing? Which one are we choosing? A, the one with the lower cost for the outcome. Agree? Or this is rubbish? Agree? All right. Cost benefit analysis is the last one we're going through. Compare competing programs, interventions with different costs, different benefits. Choose program intervention which provides most net benefits measured in money terms. This is what I always remember when I used to study. economic value, one with the money on both sides. Even your life is measured in terms of a dollar value, okay? So remember, this is not cost effectiveness analysis. This is not cost minimization. It's not cost utility analysis. It is cost benefit. And people like to use this term all the while. You're in the field, like, oh, you have no cost benefit analysis. And when they start to explain, you realize they don't realize that what they were talking about was cost effective. Don't make that mistake, guys. You need to know the difference between the four of them. The net benefit must be positive. So benefit minus cost should be greater than 0. Does that make sense mathematically? If the benefit in dollars is $100 and the cost in dollars is 100, 0. Get that? But what if you look at it as a ratio? If you put 100 over 100, what you get? That's why you need the benefit to be greater than the cost. So if you're looking at it as a ratio, it must be more than 1. If you're looking at it as a difference, it must be greater than 0. So let's look at our example down here. Total cost, we're using the same numbers for the different programs. Program A, 1,000, program B, 1,500. But look here, 100 lives saved, each earning 800 per month. So what is it in total? 100 times 800, you get 80,000. Agree? 80,000 extra earnings. So the benefit, which is the 80,000, to the cost of 1,000 is, as a ratio, 80 to 1. Program B, $1,500. 100 lives saved, each earning what? 600 per month. So what is it in total? 60,000 extra earnings. What is the benefit, which is the 60,000, to the cost of the 1,500? We're getting 40 to 1. So which one we're choosing? We're choosing A. And it's not always that straightforward, because sometimes, as you saw in the video, it might be complex to get all the different bits of information. We have used simplistic examples for you, but it's not all the while that it's easy to do, let us say, a cost benefit analysis. You have to consider other things. But this is a summary slide. Summary slide where it's just showing you cost for the different types. We are comparing different costs, all of them. For outcomes, we talk about similar outcomes for cost minimization, different outcomes, and it depends on how you define your outcome. We looked at life saved or life years saved. For cost utility, we're talking about those measures that allow us to look at different outcomes. Remember, they told that they convert it almost into a quality of life for qualities. And then for the cost benefit, remember, the outcomes are the dollar values. Remember that? You express the thing in money terms, life gain, but in money terms, if you could do it that way. And the decision rule for each is different. Which intervention is less costly for cost minimization? Which intervention has lowest cost per gain ratio? Very popular, I would say, cost effectiveness studies done by governments. Cost utility, which intervention gives better value in quality of life gain? When do we use a lot of cost utility? Because it's not something that I personally have used a lot for studies. It's quite new. It's quite new because I've worked with health economists, and we don't usually end up using cost utility. Cost benefit, which program has the highest benefit to cost? I remember that's the dollar values. And that too is fairly popular. That's true? I think so too. So one, sure. Please come.
Yeah, no, here is an application of cost. Investment. What is the rate of return on investment?
Dr. Stanley, can you speak in the mic, please? Online, we're not hearing.
invest anti-diabetes program and the tobacco control program and the cardiovascular program.
Yeah. And Stanley, would it be true to say with the tax on the sugar sweetened beverage, am I introducing something I mustn't introduce?
No.
But would they have done a cost benefit analysis somewhere in the world?
The Ministry of Finance has done its modeling to show how much money they will get from the tax. The Ministry of Health should have done its own type of cost benefit analysis. What is the expected rate of return? How many more persons will now
averted from a chronic disease? Yeah. Oh, the mic. Yes.
You asked about whether they would have done a similar type of analysis for the sugar sweetened beverage. And I'm saying, yes, the Ministry of Finance would have done a different analysis, but that we call a tax optimization analysis.
Something different then.
That's for them. But for the Ministry of Health, they should have done the analysis because you've increased the tax by so much, by how much would consumption fall, and the spillover effect of that is going to mean how many less persons will now suffer from conditions related to consumption of sugary beverages, how much cost savings the health system is going to have. And
for certain NCDs and so on, right, and so on.
So that's the investment piece.
Right. So these slides here, let me just go back up, is really what we just showed you for each of the four. But when you receive the slides, you'll see that I just combined them over these next two slides. All right, guys? So you can compare as you study. It's the very same information in these two slides that I'm showing you here. And so I want to go to I kind of jumped ahead. I want to finish off the class now with you looking, there are about 8 of you in here. Have a read through the study, the case study. It's a brief report that I was lucky to have published, worked alongside another great economist, my good friend, Abdullahi Abdul Qadri. So we are juniors to Stanley, who is a big guy. And I was working at sickle cell unit at the time. And this drug named hydroxyurea had been found to prevent a recurrence of a stroke. So you were placed on this, persons with sickle cell disease, placed on this drug named hydroxyurea. And they had noted, if you open up the paper, let me see if I can hyperlink to the paper. I should be able to hyperlink to it. Just a second. And each of you have a copy in front of you? Right. So it's a very short paper. Do you prefer if I just read it through with you rather than you go into group? So we can finish a little early. Is that okay? So everybody follow with me and then I will ask the relevant questions. Hydroxyurea use has demonstrated significant clinical benefits in reducing morbidity and mortality of sickle cell disease. What is happening here? I don't understand this, but let me close this back. Close this. Right. The majority of recurrent strokes occurs within the first 3 years after the initial insult. Chronic blood transfusion is a treatment of choice, but hard for us to get people to donate blood at the rate that we would need it. Economic benefits. So in my paper as we wrote it, you looked in the literature and other people were reporting that there were economic benefits of using hydroxyurea, this tablet. But it was reported in high-income countries. They also reported reduced hospitalization, total annual costs, outpatient care visits, and use of opioid analgesics. However, there's limited evidence in a country like Jamaica, which is a developing country. And so you'll see reference was made to a paper by Ali et al. That found that it significantly reduced stroke recurrence. It also there was, it was significantly reduced physical disability in the children following that. So this paper we did to do the economic analysis side of it, because our intention was to try and convince the Ministry of Health to have it as one of those conditions that was covered under their National Health Fund. So they would have wanted some sort of economic analysis, and that we did. And so the methods are there as to 43 children who had a first clinical stroke were recruited. And they tell you the time period, over a 9-year period, we had the data. We offered the drug. 10 of them, their parents would have given the consent. And the remaining 33, we call them the non-hydroxyurea group. They didn't give consent to take this drug. And what were the outcomes? Remember when we looked at it in the examples before, the outcomes, we had 2 outcomes. Not just one as the simple examples, or 2 outcomes. We're looking not only at stroke recurrence, meaning another stroke, but also and/or death. And after that, written in this document is how did we define a stroke? I won't go through that in the interest of time. You can speed read that. And followed up the patients from the date of them starting the HU to September 30, 2009, or if the person was no longer a part of the study, whether they migrated or whether they just were lost to follow. We couldn't find them, maybe they died, or in the case, they may have defaulted, meaning they were no longer taking the drug. But there were other considerations as we then had to develop the costs. We costed the visits. This study took me a long time. I had to send a research assistant. Maybe that is why he's such a good statistician today. Andre Waugh. Andre, he went to so many different hospitals across the island to gather the data on these patients. But in gathering the data, he had to be asking the hospital, what's your charge for making the person stay here? How much your sundries, your cotton, your IV thing cost, and so on. He couldn't put everything down, but he did create a comprehensive Excel file and we had to then decide on what you consider to be your package of service for getting this drug. You're going to need to go lab 3 times a year. You're going to have to get so-and-so drug. You're going to have a follow-up visit at the clinic, and how much does that cost? And we have to package it. The cost of a visit to a lot of different costs, and those are listed here. And you see the hospital records that they examined as well. You see that at the top of that page, the sundries, the medications. So I had to look to see if the person was on an antibiotic, what was the average time they would have been on an antibiotic, and cost it. Other diagnostic procedures, surgeries, admin fee, just to go to the hospital or go to a clinic. How much did the person, was the average cost? So when you do economic evaluation, never believe that you're going to get every single detail. I call it best estimate. And that's how life is. There are a lot of things that we do. That is the best estimate that you can get. We even inflated the cost because we recognize too that we would have had to have a base year for our costs because, prices can change. And so having started the study in 2000, that was built into the analysis, if inflation. And the next page just shows you how many unique records we use. If there was a record that we couldn't find enough information, I think there was only one of them that we couldn't find, and we excluded it from our study. And then we did what we called incremental cost effectiveness ratios. And it shows you the complicated equation that was used for this. It's a cost effectiveness study at its minimal, all right? And then we talked about what we would look at being statistically significant. So your biostats comes in. the biostats that most people hate. It comes here, it's all over. Economists have to know statistical significance where we set it, for your particular study, and we got ethical approval. Stanley, before I go into results, anything else you want to say? Not yet?
No, the comparison really was made between HU
using hydroxyurea
as against the current
regular way of treating them.
Mm-hmm. Two different approaches you're looking at. So you have the standard or the ongoing practice, and then the new one that you're looking at. So these are the two
main things. And the outcomes were don't have another stroke as well as death. Those were the two. So you're going to see now as we go into table one was comparing the outcome measures for hydroxyurea and non-hydroxyurea groups. And you'll see from the results. So here you have duration in the study. So, a table one in many studies gives you some sort of idea of the characteristics, eh? And they were comparing both groups in that initial table. Duration of study years. Was it significantly different? Have you done your biostats with Dr. James? So you remember, you always look at your footnote. Always look at your footnote, not just your title. So if you had statistical significance, you would have had a superscript with B beside it. Was there any statistically significant difference for duration in the study for both groups? No. Don't just look at 3.82 or 4.74. That's not enough. They would have done their statistics and checked for statistically significant differences, and there was none. What about days of hospitalization per patient year? Yes. Yes. Definitely at the level of less than 0.01. So the probability that this is due to chance is less than 1 in 100. And that is statistically significant. And which one was it that there were more days of hospitalization spent per patient year? It was for the group that did not get it. Number of cases of stroke recurrence per patient year. Any statistically significant difference? Yes. And which one had less number of cases? The hydroxyurea group. You seeing that? All right, 0.02, and they give you the standard deviation versus 0.19. Number of deaths, 0 for the hydroxyurea group compared to 0.04 for the non-HU group. So a minister of health, a politician seeing that wakes them up. What? Not one death? Maybe I need to think about this, or any other policy maker. The second table now compares cost estimates and cost effectiveness analysis of HU drug therapy. All right? And so you will see in the narrative on the results in the second paragraph, there was no difference in either the average daily cost of hospitalization or the yearly cost of office visits between the two groups. You agree? You agree? Yeah. So that is third row and fifth row. Am I correct? Third row, sorry. Cost of office visit, there's none here. No statistically significant difference, what I'm highlighting. Total cost. You seen it, guys? Yes. I'm going to tell Dr. James I'm pleased. You understand your stats. But the others, we saw statistically significant differences. Seeing it? Hospitalization cost per year, far more for the non-HU group. That second row. Seeing that? 45,000 MASH versus 7,000 MASH. The C there is at a higher statistical significance level. You see it in your footnote? Probability that the difference is due to chance is 1 in 1,000, less than 1 in 1,000. And so for the cost of monitoring per year, as we would have expected, much less for the people that didn't have to be monitored as much, which is the HU group. The non-HU group. Okay? Now, when you came down now to the other things, incremental cost of care of per patient per year,
number of stroke recurrence prevented per year, and all these other things. When you go back into your results, what is it showing you here? It also reveals that the ICER for prevention of stroke recurrence amounted to, and it tells you approximately how much it was in the US, while that for death prevention equaled, and it tells you how much. Is this a ratio that they're looking at here? Yes, that's why you're not seeing something in both columns. Make sense? Make sense, guys?
Yeah.
Yes, yes. So that is what they are showing you in the latter part. Oops, I'm looking for my mouse. Of table 2. Number of deaths averted, number of stroke recurrence prevented per patient year, ISO of stroke prevented, ISO of death prevented. And that's your results, pretty much, right? So table 2 reveals that the incremental cost effectiveness ratio for prevention of stroke amounted to $1,900, while that for death prevention equaled approximately $7,000 US. Is this good or bad?
I want to, my attention is a bit snagged on total cost up here per year.
Which table you're in?
Table 2.
Yes.
Total cost up here per patient.
Which one per patient here? Which one?
Total cost up here per year. That's table 2, line
5.
5, right? Cost of monitoring per year, table 2, line 4.
Yes.
Total cost up here.
So you're wondering why one is significantly different?
Well, I figure because you're following up more, you're coming in more, you're gonna be spending more. So overall, you're spending more, but the benefits is very clear.
But so cost of monitoring is a totally different. Well, is the cost of monitoring would be a part of your total cost,
right?
But they wanted to tease it out because me wanted to tease it out because you find that the various bits of information that you present will help to show you the subsets, to show you where a lot of the money is being spent. Because a minister may want to know, but monitoring involves what? A lot of lab work.
Lab work, yes, follow-up visits.
If you're going to roll this out over the country, then you have to realize you have to put some money into the systems needed to monitor. And they have to understand that there is a stark difference. But when you're looking now at, say, cost of, for argument's sake, hospitalization per year, you may say, but this presents an opportunity here. You see the hospitalizations?
Yes, yes, yes.
You see? So these are the various components that as you present your report, as a newly minted economist, you want to show, not just simply show total costs and the differences between the two groups. Kind of getting it? Now, there were some questions that we wanted to ask you as we wrap up. I can't believe we're at the end of this. Are there any other outcomes which may have been included in this study? Anybody thought about it? And I can't even tell you yes or no because I left sickle cell shortly. I might have left sickle cell unit by the time the paper came out. So I don't know. Is hydroxyurea helping with acute chest now? Yes. It is.
Definitely. I have personal friends that are on hydroxyurea and they haven't been to the clinic in a long time. It has proven to be quite a good drug for persons who have sickle cell disease. Yes, yes, if you have to end up. Anybody else in the class? Any second? Go ahead.
As if the drug is working and so on, then you have fewer patients coming to access services.
So how would you, when you said demand, how would you measure that?
Well, the number of visits.
There you go. Number of visits is one way that you could have looked at it. But they did that though, they did that. So we wanted to know if there are, well, you wouldn't call number of visits and would it be an outcome? Yes, an outcome of interest. Yeah. But not the primary outcome. Not the primary outcome.
I was thinking that same breath, I was thinking and quality, you know, it's a child, you know, other factors, education, their level of, I guess,
Intangibles.
Those are the intangibles.
Going to school, are they spending a lot of time following up, you know, is the intangible things.
Lots of school days in attendance or attendance days in school.
Calling back, stuff like that.
Yes, educational attainment. All right. Yes, but at least you're thinking. I was trying to think of something for infection prevention and control. I'm trying to remember Nurse Dawkins. Is Robert Locks? I'm embarrassed. Donella is behind you. Yes. So this is Nurse Noreen. Nurse Noreen. Persons with sickle cell disease get some infections too, don't it? Like what? Remember? I'm putting you on the spot. They actually get vaccines to prevent them. Or yes, like pneumococcal infections or so. So you never know, that might be a part of what you could also look at. Number of infectious diseases that have to be treated in these persons. Right. And you'd have to have some sort of scale to mention the mental health or psychological health of it. You had anything you want to say? I'm going to go to number 2. What are some of the indirect costs? And you see some were thrown in here. Transport, special meals that may be considered. What are some other indirect costs that?
Same school, being absent from school, that may rebound, and then we have to be paying for these children to go back in the system, ensure they get to keep up and stuff like that.
So maybe government expenditure to keep them in the school, maybe more because they're losing so much time. Anything else anybody can think of as an indirect cost? Would you call that indirect?
What about the?
It's indirect because the patient and the family have to pay that.
Yeah.
Okay.
Stay away from where they live.
Okay.
Where they have to rent somewhere for short time.
Or even the mommy has to skip work.
Yes. Productivity, yes. Yes, you're quite right. Now, here is a bummer question, but y'all sound like you're brilliant with your stats, you know. Let me see if you get this one. This is the final question for our class today. The size of the HU group, remember we said it was 10. The size of the non-HU group, 32. Could this have affected the findings? Suggest. Tell me why, yes? Yes, that's very obvious.
So it means that when you work out the stuff, the smaller the numbers you have, more like that.
Yes, so it affects what is called a word called P. And also the precision of whatever estimate you are looking at. And Dr. James, who is a guru, I just tag along with biostats, will tell you about the standard error. The smaller that sample size, the more you're at risk that there is greater variability. So you get wider confidence intervals. So I'm not putting you on the spot to explain too much here, but when you go back in your quiet space, look back at that. It has relevance to this. Anything else that would be affected with these different sizes?
And the risk of so it's small sample size, you have individual. So one patient might have multiple.
So power, the confidence, the precision, what else?
It's gonna come back to it.
All right.
Just remind me, was it patient consent when you see that this which one?
Sorry?
Was it because based on patient consent? That those who wanted HU as against?
Yes, it wasn't randomly. There was no, and I'm giving away the answer, Lord of mercy.
Selection bias.
Yes! Yes, we didn't force anybody. Oops, I shouldn't have said that. Yes, but you get it. So you may have some selection bias there. There may be a reason, fair, or they think it would be, they'd have to come back for that, because they had to, when you go on HU, you know, I think in the first 3 months, you're coming at a particular frequency, almost far more regularly, and then it peters out. I don't remember the regime right now, but there are some things you have to do upfront, a lot of, because the drugs, all of these drugs have their side effects. So you may need baseline, liver function test, kidney test, that. You want to come in the early days, maybe every week, versus as you go along with the treatment, it might be every month or every this. And sometimes people don't want to commit to that. And it may have what you call it, what type of bias you call it, when you don't recognize the bias. Oh, it has just gone out of my head. It may introduce the sort of bias that you don't recognize that points to there is some specific feature about the people that didn't want to take the HU. I just can't remember the name. I can't remember the name. There's a name that they use it. Have certain characteristics. Yes. Their educational level may be higher. They may be richer. So they may live in Kingston. So if you have that bias, therefore, it may be that your findings may not really be truly representative. And that is why for every study you do, you write your limitations. Nobody expects a study to be absolutely perfect, but is it worthwhile publishing this body of work, given that they stated these are possible limitations? Because in spite of it, may say it may still be worth the while going ahead with this, and the government did. The government did, and they put hydroxyurea as one of the drugs that's on the NHF. The people, I remember Dr. Knight Madden, who headed sickle cell unit at the time, was able to rally for it to go on the NHF and so on. So when you see anybody and you see that name on the card, remember me. Remember me. I had a little part to play in it. And so we have come to the end of the lecture, I think in fairly good time too, if I may say so myself. And as we look back at the learning objectives, you would be able to list some health resources? Guys, yes? Yes. You'll be able to talk about how one may review criteria used to prioritize health programs. Oh, I spelled prioritize wrong there, sorry. You'd be able to discuss the role of economic evaluation. And we talk about some of the differences in those measures. 4 key ones are cost, organization, cost effectiveness, utility, right, which is the one that they talk about with Qualis and Dallies. Yeah, okay. Which one you need to have the monetary outcomes and the costs, everything in money terms when you're doing the cost. Yes, so at least you remember the basics, right? So I wish you all the best as you move forward from here. We have a reference here that you can look at. WHO has good sites that talk about various aspects of this course, including economic evaluation. Read a little. My email is on the first slide. I'm going to just tidy up a few things and give to the secretary that she can share with you. I hope to return with Stanley sometime in May. Hope, if my other responsibilities will allow. Don't you like to see me back? I enjoy teaching. I enjoy teaching you. And as I say, if you have any questions too, feel free to send me an email. If I can't answer it, I'll ask Stanley. All right. Thanks for listening. Take care then too.
Thank you very much.
All right. I'm going to leave you with him to spend the rest of your Friday.
No, we don't intend to.
Okay.
Could we just take a quick break and then come back in about
Sure.
15 minutes, because I want to be out of here like about 5:30 or thereabouts. Let's do that and come back in here.
Okay, so I am going to, I think I can just leave here then. Your thing is probably.
Yes.
All right. Okay. I made it. That's it. I made it. Right there, yes. It's always good to relearn, you know? And
Okay, thank you. Just to indicate that this is the next session that we're looking at in health economics. And today we're going to look at the matter of health financing. The first session, because there are two sessions on health financing. The next session on health financing and a couple of the other sessions, I will have to do those online. Before we do that, I told you about some of the mini research topics which I wanted to pass on to you, so you can organize your time, organize yourselves into a group, small group. And the good thing is that Dr. Thompson has selected for you. Makes it much easier. So there's no fighting. Don't call me to sort out any battles that you may have as to who is in which group. She has done that, so you can take it up with her. And for example, and there are about 8 topics which we have, and these have been assigned to groups of 2 or 3 people maximum. 3 people maximum. And like one of the topics here which we have pertain to the whole business of take a non-governmental organization, for example, in health. You have diabetes, you have the Heart Association, you have the AIDS Society, you have the Cancer Society, and really try to dig into a bit more about the work of the organization and particularly how they are funded and how they sustain their activities. So that's something which you will want to look at, because NGOs play a crucial role within the health system. And so that's one topic. And I have, in addition to looking at the topic, I'll give you some of the key areas that we want you to address in relation to that particular topic. So you have to organize your research around that. I will share some things online in terms of how you develop the research outline and what is expected, and that will come over time. A second topic could be in relation to this one, and we were just speaking about this. We know what is the proposal for the sugar-sweetened beverage in Jamaica. Now let's do a bit of comparison. There's information available on the tax in Barbados, which again, I want you to compare with the tax in Barbados and the recommendations that have come out from the WHO to see whether Jamaica is in line, out of line, are we getting it right, or are we not getting it right? What can we learn from Barbados, the WHO? What can we learn from the tobacco tax that you have also implemented in Jamaica? Are there any lessons that you want to transfer so that we can see whether we are going to be getting it right in terms of the sugar beverage tax? That's something to look at. By the time you finish, it may be too late, it may be passed in Parliament, but there may be room for adjustments and so later on. This is another topic which I find very interesting because I mentioned it to you. You have about 20 years of data which has been collected in the Jamaica Survey of Living Conditions. There's a health chapter in that survey report. The reports are available at the Planning Institute, and they also will be available, I think, at your main library over here, or in the Salises library right here on campus. So probably you can get that. I think some of the reports will also be available online. So, you know, hard copies, online version. I'm hoping that you don't have to pay for it. Hopefully, all right? But the good thing about it, as I said, is that the report, the health section, asks us some questions about Were you ill or injured in the last 4 weeks? If you were ill or injured, did you actually seek care? So that can give you a very good idea what percentage of the persons who were ill did not seek care. Now, they've also broken it down by what is called quintile groups, which is income groups. So if you want to do an equity analysis, you can begin to use the quintiles to determine are poor persons declaring the same amount of illness like rich persons, but are they seeking the same amount of care? And it has the places where you go to seek care. Do you go to the public facilities or the private facilities? It asks about chronic diseases. And again, you can do an equity analysis in these. And it asks questions about your spending. So there's a lot of room for equity concerns. The near poor, quintiles 1 and 2, are at a disadvantage compared to higher quintiles. Also differences by sex as well as area of residence. So adequate data sets there for you in order to look at. And I don't want all 20 years or whatever, just look at the latest year. Look at the latest year, I think that should be 2021 or 2022 or somewhere around there. And there's a group which is going to look at that. This one over here takes a look at, select a country that interests you. And I just make a suggestion, look at Canada, Colombia, or the UK, and look at their health financing system. The UK use budget or tax-based system. The Canadians use a social insurance, health insurance. The Colombians use a social health insurance, a different type of financing arrangements they utilize. See how that works out in practice in these countries. And this is more a reading exercise. There's several reports online, etc., which you can get. You read.
I'm sorry, we online, we're not able to hear.
All the way.
Hearing no.
Yeah, we're hearing now.
Oh, is that oh, here we are. Saved by Miss Prince.
Oh, you're the designated.
Right, it's now coming around to you, so you can see what are the topics and which are the teams. And I will be online to provide any guidance, any support, any additional research material that you will be looking for. All right? That's it? Is this what you got?
No, we got the
This will be the next one that you will get. As I said, this is one which the office has, and we just cleaned up this in discussion with Dr. Thompson. So she will give this to you, and you will see where you are in terms for the which particular research exercise you will be asked to do. As I said, I'll be online so we can compare and run any questions, and I have suggested readings which I can give you. The other thing is, which I want to draw your attention before we go into the topic itself, is in terms of the schedule has some lectures which will be online, and a couple of these I will do. And then as I said, I return in May, so that there are a couple of lectures and then the presentations from you. And there's some open sessions in case there anything spill over, course review or any other material you want to check on, so you can do that while I'm here in May. And then of course you enjoy your Easter break. I'm not going to interfere with that. Public doesn't have Easter break.
Busy studying. So I can just ask who don't know. I just want to see my name, please, because I've seen my name.
No, you have to get this one to see on the kit, not this one. This one was my original version, but it was adjusted by Dr. Thompson. So the adjusted version, you see, and that's the one you need to get.
I'm going to take a picture and send it to the group.
Oh, you can do that.
Thank you.
I hope they know the changes in the office. No, go ahead, go ahead.
We don't get
Go
it
ahead.
today, because they already started it, so.
Yeah.
So sorry, you're saying this is the adjustment copy.
Okay.
That's the baby. All right. Right.
Original. This is original. This is the corrected final.
This is an adjusted version. That's the one you'll be relating to.
We're gonna find out which one so okay.
All right. That's a real one. This is the imaginary one.
The work is piling up, sir, so we want to, get it.
Yeah, we need to know in real time.
Especially when our weekend is right around the corner, you want to know what am I doing for next week.
All right, so I've clarified that. I've clarified the timing in the program and when I will see you next. So let me finish my exercise for today and do this. This is the topic which we want to look at. It's available to you hard copy, but it's also should have been sent to you online, so then you have both of them that you can work with. The matter of health financing, is one which we have been speaking about indirectly. Well, Sebastian came and adjusted, and he said that.
You could ask them, sir.
Right, online, are you hearing, seeing?
Yes, I'm hearing and seeing. Are you hearing me?
Simone?
Yes.
Does that
Okay,
mean yes,
awesome.
green mean yes?
Yes, sir.
Oh, we're not hearing them through here, but I'm hearing them on this. So I don't know if it's on mic. Well,
We're hearing
it's not on mic,
but
but they're hearing you, sir.
They're hearing me, but I can't hear them.
Hear them. Right. So
It's something that Sebastian did.
Can you reconnect
Can
the
somebody just knock on
audio?
the door and ask Sebastian, how do we deal with that? Okay,
Thank you.
all right.
Except for one minute. Except for the request for the-
No? I didn't. Oh,
Who touched that?
Okay, thank you.
Somebody online to something to make sure we're hearing it.
Something.
Hearing online, Daniel? All right, we can hear you now. Thanks much. I'm saying that the our presentation today looks at the matter of financing, and this is the first of two presentations on financing. References, they are here. And if you can get some of this material, I will try to send these to the office and they will get it to you. But things from the OECD, the World Bank, the WHO, all of these are online materials, so you can get these. The main themes, the main areas I want to run through in the session, look at the components, the goals, the components of health financing, the best practices in health financing and the health systems themselves, matters pertaining to the paying providers, efficiency, and all of these things will be picked up in the next session. Right, take a look at this slide, take a look at the table. And tell me what strikes you, what hit you immediately. Oh, well. A mix of rich countries and poor countries. All right? Uh-huh.
Insurance, capitalism.
But we want to relate spending to outcomes.
Right, but there, when you look at the United States, for example, China and Cuba, you have the same life expectancy. In China has lower child mortality rates, and because it is one word.
You can't, I don't know. But
Daniel?
I wasn't sure if somebody else was talking, so I wanted to wait.
No, you're on now.
Oh,
You're on now.
okay. It's more so the case where you can't directly say that the amount it is that one spends has to effectively correlate to what it is that the life expectancy or child mortality rate looks like. I mean, you have extreme cases like in the case of Nigeria where it is that they spend the least, and by virtue of that, you'll see that the life expectancy and child mortality rate are amongst, I want to say, the worst. But if it is that you look at, say, between, like maybe between like Cuba and China, they have, Cuba and China. You could probably even look and say
No, you're right.
between
Cuba and China much less spending.
much less spent and at the same time still getting pretty decent, for want of a better
Yeah.
term, mileage out of how much it is that they spend. Yeah. Especially in comparison to, I want to say, countries that are spending significantly more. It kind of plateaus at a point. I think like basically after maybe 2,000 US dollars, they're roughly
Yeah.
thereabout. Like there's not much more it is that you can say you're getting in terms of like life expectancy or child mortality rates. But then that raises a question of like how much do you value an additional year of life?
Where's the best place to have children?
Japan.
I mean, I feel like you'd want to say Japan based on this, but Japan also has a very low birth rate, so that's a very small sample.
Yeah. Well, I don't know if it's small, Japan has about 100+ million people. So it's pretty well populated. If you want to live long, where would you go? If you're 74 years old in Jamaica and your life expectancy is 1 more year and you want to live to 84, where would you go?
Japan.
Oh, time to migrate.
Or Singapore.
Yeah, no, Daniel, the point you're making is very correct. There's no automatic relation between how much you spend and what outcomes you are going to get. There are a number of intervening factors, and some of these things which we will see will pertain to the efficiency of spending. And it pertains to how the health system is organized to deliver care. And this is one of the things which the developed countries found out, that because they are more curative care oriented, that sometimes they keep spending more and more on facilities and on health, but they're not getting comparable returns or proportionate returns as in relation to other countries. So that's something which you want to look at, and you can.
So you can correct me, but it would seem that even though the US, for example, that 12,000 in terms of the value of each country's GDP and what they're putting into it, it would seem that even though some of the countries have a smaller GDP, just looking at the figures in terms of the percentage of GDP, when you relate it to the actual value, it would suggest that they do give a bit more primacy to healthcare, even though the figure is on the face of it lower.
Yeah. And then I expected you from public health to give me another version of this. What is missing? What is missing? Not because I'm standing in front of you.
The vaccination
because the
levels?
screen talks about health spending. You relate in outcomes to health spending only. Remember
Are you
your
talking
health,
like-
your outcome. Your
Like
outcome
qualities?
is not totally driven by what is happening in the health system. That's why you have social determinants. It also depends upon your food, it depends on housing, depends on education, depends on a whole number of things. So it's not only the health system determines child mortality or determines life expectancy. How good the police are could be a factor that you also have to bear in mind. So that's what, from a public health point of view, as against a strict health interpretation. And when we put this table like this, what's the implication? The implication is when you go to the Ministry of Finance and you tell them health wants more money, and the Ministry of Finance asks you, but why? And you say, well, you know, health is important and health is basic and all of that. You say, yeah, but people will have the life expectancy longer, not because I give you the money in health, but because I put the money in other sectors. So why do you automatically think that I must give you more resources in health and so people will live longer and all of these things? The argument kind of work against you. So you know, you have to know how to put your case to the Ministry of Finance. Otherwise, they could keep turning it against you. Secrets of the temple. Right, health financing. Let's see how we get it right. I mean, getting health financing right is not just a money matter. It is also, as we know, a political matter. All right? And that's why I put the cartoon on the right-hand side. I think you all will remember that. And I think the debate is still going on. Whether you want to roll it out or to roll it back. That's bigger than just health and health financing. And in this one, where it talks about the cost of financing and the cost of the health system and the cost of treatment, well, the prescription says we should take this until it is empty. Well, what should be empty? The bottle of our savings. All right? Remember this? I think, did we speak about this before? So you can see where health financing fits into this. Financing is not the most critical input or building block. It has other building blocks within the system that you have to interact with in order to find a good or highly performing national health system. Health financing is not just about raising money. That's the tragedy which we face when we look at persons who are talking about financing. Financing is not just getting money. It is how you're managing the money. It is how you are spending the money. Are you getting value for money? Are you being efficient? Are you spending on the right things? Or are you spending on things which should not be your priority? That's an important part of all of this. How do you pay your providers? Is that driving your spending? Should you pay them differently? And we look at different ways you can pay your providers to get better value for money. Are you minimizing waste and leakage? That's just as important in health financing as how much money you're collecting. And on the collection side, how much money you generate, that depends very much on what is the mechanism that you are using. If you're depending on the tax, your money that you get in your budget depends upon how much money the government is collecting in taxes. So when you tell your friends how much customs duties you did not pay when you come to the airport, and when your business friends tell you how much taxes they did not pay because they found a way to beat the tax system, it is going to come back on your doorstep in health. Because the amount of money you get in health depends very much on how much money the government system is getting overall. Okay? So you have these kinds of things. And then what about those who are managing the money? If you're part of a health insurance plan, what is the objective of the health insurance company? Is it to look after the interest of its members, or is it to make a profit for its shareholders? And so you have to ask a very big question. Then, are they managing the money properly, or are they seeking their own interest as a result of their operations? So you can't automatically assume that a company that is managing the money is going to be managing it in the interest of the patients. You can't automatically assume that. Even with the Ministry of Health, you cannot automatically assume that those who are working in the Ministry of Health are working in the interest of the patients. It could be that their job is more important. So, you have to look at what is it you're trying to maximize. Is it that those who are working in the Ministry of Health, you see, my department should be getting more in the budget than that department? Is that in the interest of the population? So how do you begin to organize that? So don't automatically, again, assume that whoever is managing the money is doing it in the best interest of the health of the population. That's part of what you have to balance in the equation. 4 main challenges that all health financing systems face, not just Caribbean countries. One is the big challenge over here. You have 3 different groups which are part of your health financing system. Doesn't automatically mean that they sing from the same hymn sheet. Doesn't automatically mean that they work together. What the patients want may not altogether be in sync with what the health providers want. What do the health providers want out of the system? All right? You pay for the providers, and the payment can come from the manager. As I said, if probably, for example, the health insurance company wants to delay payments to the health providers, you send in your claim and they want to delay payments because they want to invest in treasury bills, or they want to invest in bonds or something like that and make a return for the money they've been collecting, then they say instead of paying the providers in 30 days, we're going to pay them in 60 days. What do you think they're going to do in that next 30 days? And they can find a whole lot of reasons why they tell you, we can't pay you now, or we're not going to pay you now. Oh, we have to screen the bills. We're not too sure that this claim is a valid claim or not. We have to go back and check all of these things and whatever. And so they can begin to do some of these things. Can you automatically assume that the health providers are working in your interest? Health providers, they want to maximize their earnings. When you're in the dentist's chair and he or she has a probe in your mouth, I say, not looking good, not looking good, looks like we need to do an x-ray on that. That cavity, might have to take out the tooth, Or you want me to cap it, or what do you want me to do? Root canal may be needed if you want to deal with that. I mean, are you in a position to determine whether that is absolutely necessary or not? Or you just have to take what the provider is recommending for you? How do you know that what the provider is trying to do is not extra bill or provide extra service? Because the more you do, the more the provider gets. Is that going to be driving their behavior? So don't automatically, and what about a patient? You part of your health insurance plan. If the premium keep going up all the time, you might think twice about, should I belong to that plan or change the plan? You want to keep your premium down as low as possible. So if the providers are doing things to send up the cost, if the fund manager is managing the funds in a way that the costs are not, the bills are not being paid on time, and the providers tell you, well, that insurance company taking too long to pay me, you, the patient, pay up front, and you go and claim from the insurance company. Now, in a case like that, the patients will feel disadvantaged So then don't automatically assume that the interest of the patient, who would want to pay as small amount as possible and get all of these things, is in line with the other plan. How do you balance these competing interests is a big part of health financing. Right, second major problem is this one, which is quite common, which you know, if you don't have the money, you can't get the care to a very large extent. Even when it is public, you may not have everything provided in the public sector. And so you may have challenges with affordability of health services and access to health services. And globally, the WHO has data on how many persons are affected by that. Sometimes, in order to pay for your health care, you have to spend such a significant chunk of your monthly salary or whatever it is that it becomes catastrophic. You have to cut back on food. You have to stop paying the rent for 2 months or something like that. You have to stop paying the bank loan for your car or something because you have to raise. That is what's called catastrophic payments, health payments, and it can cause major, major consequences. And around the world, the WHO has done analysis on that. In fact, when you're doing, if somebody, whoever is doing the work on the survey of living conditions, probably you may be able to pick out some of the data on what percentage of Jamaicans are spending such a huge share of their earnings on health services. So if you can pick up that finding from that over there. And of course, the consequences when you have to sell your last chicken, you have to, stop paying the rent, or you have to stop the child from going to school, or not seek health care for your condition, because you don't have the money to pay for it. Or when you go to the pharmacy and he tells you what is the cost of the prescription, say, can you give me 1 week only instead of 1 month? Or you have the prescription item and you start to stretch it. Break the tablet in two, or borrow tablets from your neighbor or something like that. So there are a number of things that you can begin to look at in how persons begin to manage affordability. Third challenge is the one which we've just looked at. Doesn't automatically mean that the more you spend, the better your health outcomes are going to be. Depends very much on efficiency of spending. And this one, all countries also face the same challenge in this, that resource gap. And that's the topic which we just covered with Colette, the whole matter of resources are not unlimited. Resources are scarce. Resources are limited, and you cannot do everything for everyone. But here we have the demand and the cost of health services rising faster than the availability of resources. So you have this gap, and we have all of these factors responsible for the increasing demand and the cost of services. Aging population, I think we were speaking about that the last time, that you can't stop people from getting old. You have to make provisions for those. Chronic diseases, can we curtail that to some extent with more healthy lifestyles, etc. Technology advances, inefficiencies in the health system, workers' demands, expectations, all of these are driving cost and demand. And then resources are not growing as quickly, so you have to try to balance the two, and all countries face that gap. And how do you close the gap? How do you manage demand and cost, or how do you get more resources? Part of the challenge. If you want to organize your health system properly, then the WHO has some suggestions, and that's why they put it all within the framework that they call universal health coverage. Try to make sure that everyone has barrier-free access, no discrimination, and no challenges in getting access to a defined package of services, delivered efficiently, quality standards, and all of these things. Another way of doing this is to put it diagrammatically. And there are three real dimensions of universal coverage that you're trying to get in your country. The first one, the horizontal dimension, is where you must try to get as many people in the population covered. If some people can get services and some cannot, you have a problem. So first dimension, coverage of the population. Second dimension on the diagonal is what mix of services you are providing. Does the mix of services respond to the epidemiological burden of the country, the pattern of morbidity and mortality? In other words, the greatest need within the population for the greatest number of people, is that the kind of services that you're going to provide? And you're going to work out that since you can't provide everything for everybody, then you're going to have some gaps in your service coverage. And the third dimension, of course, the vertical dimension is, do you have money or the resources to pay for all the services that you might want to provide and to cover all the people in the population? So at any one point in time, we can do an assessment of where Jamaica is, or where Trinidad is, or where the US is in relation to my cube. And you can begin to see how much of it you fill, and what are the shortages, and what are the gaps, and where the shortcomings, and therefore what progress you want to make over time. That is how you begin to measure universal coverage, and how you can see, well, by 2030, when we should all have everything solved, how close are we to filling up the entire cube by 2030? And we're now in 2026. Some measures, some lessons, the WHO lessons for appropriate health financing system, three things: revenue generation, how you manage the money or pool the money together, and how you spend the money. Three things: you must use compulsory revenue generation mechanisms. Don't make it voluntary, like private insurance. What happens if you make it voluntary? Some people will join, some people will not join. Some will contribute, some will not contribute. The young and the very healthy and whatever will say, well, we too, healthy. We don't need to be joined. We don't need to be part of any health plan. We're already good. The elderly persons also going to say, well, all of us want to come forward and be part of the plan. All the little children, we want to be part of the plan because we need health services. But can you run a financing system like that where only the sick people are part of the plan? Remember Mrs. G and the health insurance premium that she had to pay? So think about it like that. If you have a voluntary payment system, you're going to run into problems managing your health. So you need something compulsory, like taxes in the UK, Sweden, Jamaica, or payroll contributions, national health insurance, like Germany, Japan, Aruba, Cayman Islands, Turks and Caicos Islands, and some of these. You want to make contributions fair, that is based on your ability to pay. And I'll show you how that works in practice. What does that mean? Those who earn more should pay more, or should contribute more. And those who earn less should contribute less to the pool of money. How do you do that? Now that's where the tax system comes in. Because when you have a 25% or a 30% or whatever it is, those who earn more, 25% of $100,000 is a lot more than 25% of $1,000. Is that fair or not fair?
People are complaining about that right now, sir. Like, out of the pay where you an exorbitant amount of taxes, and there is a pool of people who don't pay taxes at all, but you still have access to amenities. Like, how do you capture that pool of people who seemingly are uncapturable? That's how would they benefit from this?
Right, and that's why you have something called GCT. Because if you do not pay, the thing about it, it's not only the direct tax based on income that you generate tax money. You see that thing that you call consumption-based taxes. You can't get away from that, informal or formal sector.
Right, sir, but there's also, as the gentleman raised the conversation, that we should eliminate the PAYE and just go with the GCT, and then where we can say, all right,
Talk to Antigua about that. Talk to St. Kitts about that. There are countries in the Caribbean where they have no.
We also have a lot of businesses in Jamaica that are not registered, that never ever paid a GCC or anything. So, half of those stores don't talk to that.
Yeah. Yep.
It's true, we have to, I guess, a proper risk.
But I think
so. So that's the other end. No, it means that we have to do better regulation of these entities.
And that's where what is called the efficiency of your tax administration plays a very, very big role in this. Yes, you were saying?
I was saying in terms of curtailing both issues, I always go back to information systems, because if you have a national system where every baby, every adult, every business, every single person who comes and is a temporary resident in the country is registered and is forced to be in that system, then it provides a framework from which you can trace activities and contributions and stratify benefits a lot better. Without a functioning, broadly reaching information systems framework, people get to slip out, and people get to conduct businesses. Mind you, not to say we want a surveillance state, you know, a dystopia where you can't even breathe a molecule of air without the government knowing. But I mean, at the same time, there must be a balance where the monitoring is robust enough. But I guess
I don't think
you want
persons.
to be the business too much. You want all the information, and then you know it's a very delicate thought, but information systems.
I don't think persons.
Sorry, Daniel, you had something there?
Yeah, I just don't think persons really have a problem with respect to like surveillance states, air quotes, if it is that they see that the surveillance state comes at a benefit. I.e., if it is that because it is like in just regular day-to-day life, right? You sign away, I want to say, your data information whenever it is that you go on any apps and whatnot, you click the I agree to the privacy and policy terms, even though it is that you never read any of the terms and conditions. So it's pretty much an extension of same, is that you just have to make it so attractive that it's okay, what it is I'm getting is worth, I guess, this idea of what it is that I'm signing away. And if the system works well enough, then persons don't even notice that it is that they're giving away what it is that they don't necessarily consider to be private information. But, and that's something it is I see in like China, where it is that everything is very tracked, everything is very, I want to say, it's very traced, they're very surveilled, right? And it's something that the US would kind of lambast China for. But US citizens are also surveilled in much the same way, but they don't see any of the benefits that it is that you'd see across the sea. So,
Yeah. And in Singapore, of course, if you stick chewing gum in the subway, then they know who you are.
And they've launched
exactly.
This is a digression, but they've launched the drone system that now notifies you. The drones are watching you. And if you commit an infraction, the drone notifies you that you will be prosecuted and something will be sent to you. So, but it's kind of dystopian and scary, you know, you can't even, they're watching everything.
Dystopia implies a negative. It doesn't have to be dystopian.
It's kind of dystopian, but that's not really dystopian.
Do you remember a book called 1984?
By George Orwell. Yes.
George Orwell, Big Brother is watching you.
Yes.
Every single thing that you do, Big Brother is watching you.
There was we just don't know. Right? But let's not digress. But I think so.
Yes. So make contributions, share, tax system, etc. Use prepaid as against direct out-of-pocket payments, primarily because in the Caribbean, there's a culture, why should I put my money into a plan like a health insurance plan when I am not sick? I will only spend money on my health when I am sick. But that's the time you don't want to be looking around to determine, do I have enough money or not? So this is where don't have systems where you have to depend on out of pocket, because some people's pocket, like mine, are very shallow. compared to other pockets. So therefore, you cannot say altogether that I will be able at any one point in time for a major illness that I will cover it or not. So out of pocket, problematic, and it has to be prepaid or put into a plan in advance. And this is where the whole matter of tax systems and health insurance systems become very crucial. The WHO says across the world, comparable countries spend about 7 to 8% of GDP on their health system. And that's why in the table, I had shown you what percentage the Caribbean countries are spending. And I think Jamaica is just about 8%, although I'm not too sure whether that is a statistical quirk. In 1 year, this is 2023 data. What is happening in 2023? You got a lot of money from COVID still left, maybe. That's why you're looking good. 2024, it may have come down, or 25 may have come down. Yeah. But you should be somewhere around 7 to 8%, okay, if you really want to do well with universal coverage. Pooling, use a single fund, not multiple fund. Subsidize the contributions of the poor so that they can get access to the same package. As we said, not everyone can be able to contribute the same amount, so you want to make sure there's equitable access for the poor. What do we mean by equity?
What does subsidize look like? Is it that if they pay $10 and the cost is $20 to government offsets the $10 difference?
Subsidize has several different meanings. If you have a social or national health insurance system, then the government pays the share of the contribution for the poor, right? And all those who are working and a little bit better off, they have to pay their own contributions. So the subsidy over there could be a full subsidy or it could be a partial subsidy, depending upon how well and how efficiently you can identify who is poor and who is not poor. Now, the PATS program and the other systems and so are supposed to be doing that. And if it does not do that properly, you're going to have challenges because you know that there's some people who are permanently poor.
No, but in that same breath, sir, disabled, so there are going to be certain classes of people.
And certain groups, not just the poor, could be vulnerable, could be disadvantaged population. All right, so it doesn't always have to be poor persons. And that's why, remember when we were looking at public goods, I mentioned something called merit goods for some groups who you think really deserve that because they can't think. All right, here's what part of the subsidy or the support is going to look like. Equality in health is not what you're looking for. You're looking for equity. There's a distinction between the two. We are all equal in the left panel because each one of us has one box to stand on. But can we all benefit? Can we all get access? Can we all reap the fruit? Could be an orange, a grapefruit, or something looking roundish. All right. So what you have to do is there are some persons who need a push, and we know that in the health system, some people who need a push, some people who need a help, some people who need to get a shoulder to lean on. So some of them require what we call 2 boxes or 3 boxes, but then you don't have equality anymore. What you have is equity within the system, and that's what you're trying to do within the health system in order to get access. In terms of financing, that's also what you try to do, because what you're looking at altogether is how do we organize the system in a way so that you can get the benefit for everyone within the population. So some persons need to get a push, and that's where the subsidy and the help is going to come in. I like the cartoon, I like the diagram. Now that I look at it. Good.
I don't know, I thought on that.
Right. Yes, sorry. Sorry, yes, Daniel.
I don't know, it's like a small thought in terms of this representation of it. You've kind of seen it a lot over the years, but I do appreciate the use of a tree in this instance because it kind of shows that no one really kind of creates the resources that it is they have access to, like they're naturally occurring. So it would make sense that it is that person's, that you make a system that everyone has equitable access to a naturally occurring resource.
All right. Probably in my next version of the slide, I'll begin to make some changes. Yep, that's a good observation there. Right, we spoke about universal coverage. Are we there? Is Jamaica looking good? I put the Caribbean countries in here, where you were in 2000 and where you are in 2023, which is the last year that we have data. Are you looking good? Anything above 60%, you put it in a high category. Above 80, you are very high performing. So if Jamaica over here, as we see, is 74% in 2023, then you're very high performing. Why aren't you smiling?
Because in the distribute, you have to think about the geographical distribution. And you have the concentration in urban and peri-urban areas, and then you have inverse care, realized in more rural and remote areas. So it's not just
this is average, and you know the problem with average.
Right.
The average, you have the extreme situation where there's distribution issues now play a very crucial role in this. So you have to look at this with a grain of salt. But looking good if we were to do this in 2030, which is what universal health coverage by 2030. SDGs, Sustainable Development Goals by 2030. I wonder where we will be. Maybe by then you will be part of the research.
The disaggregation, service coverage access, because we might be doing well in the maternal child in that section. But when you get down to that tracer, service coverage access, distribution, we might be doing very poorly there based on things I see.
And that's another aspect of the thing, which you look at. I mean, are these the critical service areas that Jamaica has to contend with? Or do you think that you've done fairly well in maternal and mortality thing, and so you will always look good? Infectious diseases, you're looking fairly good in that. Chronic diseases, when you disaggregate the data, Jamaica scored very poorly on chronic diseases. So you could score 90 on reproductive and maternal health, but you only scored 40 in chronic diseases. So there's homework to do.
Professor?
Yes. Simone?
Yes, sir. Why did they do the average without Haiti?
It's really sad.
You mean why did we do it with and without?
No, without. It was without Haiti included.
Yeah.
It's on the table. It's just that they're showing you the score we've done without it.
There are a lot of other.
And I mean, isn't there a case to be made that since like a lot of the countries here would be considered high, right? High to very high. Can that give pause to say that it's a bit shameful that as much as it is that Haiti is a member of the region, like their outcomes are just significantly poorer?
No, that's a big part of the arrangement, which keeps coming up all the time. Sometimes we include Haiti as part of the Caribbean, sometimes we exclude it for convenience. Sometimes, for example, we want to say that why not include Cuba? Why not include Martinique and Guadeloupe? All right, so there are a number of things. Haiti is part of CARICOM, but then some persons may say, but it is not all CARICOM arrangements Haiti is part of.
Professor, I'm thinking though that if Cuba were a part of this, they'd have a pretty good universal health coverage going for the country.
Yes, we should look better. So the average for the Caribbean would look better. But what about if we had put Puerto Rico inside here? Puerto Rico should be good. If we put Cayman Islands inside here, Turks and Caicos Islands inside here, looking good. All right, so that there are countries which you would like to see inside of here. And that's part of the whole thing. But Normally, generally, when we're looking at within the CARICOM arrangement, you look at the English-speaking countries and to some extent Suriname, because they've been there for a fairly long time. Haiti is more recent as a member, so that we're now beginning to make sure we have data on Haiti. All right. Financing systems around the world, mostly going to have a mix of financing systems, some private insurance, out-of-pocket spending, social insurance, tax-based spending, etc. You can look at low-income countries. What's the mix they have? They have a lot of out-of-pocket spending because governments are weak or small amount of tax collection, and there's very little health insurance. So a lot of out-of-pocket spending. Middle-income countries, you have a better balance than high-income countries, like in Sweden, Japan, France, the UK, etc. They depend a lot more on public sources of financing, whether it's through tax sources or social insurance, and we'll see how that operates. And where is the Caribbean going? Where is the Caribbean going? I'll show you why I asked that question. Around the world, the two main health financing systems are the public financing model, where you get your money from taxes and you get a health budget in health and you run the programs in health. United Kingdom, all the Scandinavian countries, Brazil, and most of the Caribbean countries have tax-based health financing system. Other countries depend upon social insurance contributions, payroll deductions, which are made, and it goes into the pool, and from that you're going to pay your health bills. So you have single pools, single agency, like in Taiwan, Costa Rica, Aruba, Turks and Caicos. You can have competing public and private pools in Germany, Colombia, etc. You can have competing private pools, Obamacare in the US, where you have private health insurance companies which are providing the coverage, or in the Netherlands or in Switzerland, where they have a legislation which says you must have health insurance, but you can choose any private insurer to get it from. So you can have all of these different types of arrangements. And one very, very unique case, which nobody else has around the world, is what is called mandatory medical savings account in Singapore.
That's interesting.
Medical, nobody else has that kind of system. And of course, we saw the kind of health results which Singapore seemed to be getting. Why? Is it the financing system that is helping them?
Out of the two that you just outlined, where would Japan fall? You know where
Japan is there with social health financing, social health insurance. Right, right over there where they have. And Japan has what is called competing public and private pools.
Okay.
You can have your national health insurance program and you can have a single agency running it, or you can have different agencies, public and private. Like in Bermuda, for example, you have competing agencies. All you do is you pass the legislation. Everyone must have health insurance. And then you leave it to a public insurer or a private insurer to offer the package. And you can buy your plan from the private insurer or the public insurer. You make the contribution, so it can be managed like that. It doesn't have to be always a public provider that you can get your plan from. I'll come up to this.
How does the fee, because especially when you look at the cost of healthcare in the US,
yeah,
and the role, then you start to know about the role of private insurance companies and how they're driving up the cost of everything. And probably that's the how much you want
When we look at all the lessons which we want to learn from health insurance, remember this one over here that we put up, the WHO said pooling. Use a single agency as against multiple agencies. Single agency, you have more economies of scale. You don't have to be advertising and spending money on marketing and advertising. You don't have stake shareholders. You have to give them returns at the end of the year and all of that. You don't. Other countries, however, they depend on what is called democratic choice. Population determined, we want a choice. So you have a choice of insurer. Some countries say, no, there's no choice. So it depends on what are the value system of the country, not just a straightforward matter of what is good for health. There's some bigger factors which you have to battle with and contend with in the country. I mean, the decision on the sugar-based tax is not just a health decision. There are other bigger issues which you have to grapple with. All right. In the Caribbean, what do we have? And we can't automatically assume that all the Caribbean countries have the same kind of system. If 50% or more of your health spending is coming from public sources, then we put you in this category called a tax or budget finance system. And when you look at the data, you will see that about 70% of all health spending in Jamaica comes from tax sources, the public system, and a smaller percentage from the private sector. Other countries is a bit different. So if more than 50% of all your health spending is coming from a particular source, I put you in that particular category. So countries like Anguilla, Antigua, Belize, Dominica, Jamaica, Guyana, Montserrat, St. Vincent, the bulk of their health funds are coming from tax sources. Other countries, the bulk of their health funds are coming from social or national health insurance. And this is where you have Aruba, Bermuda, Cayman Islands, Curacao, Suriname, Turks and Caicos, Bonaire, Martinique, Guadeloupe. So it's not like all countries in the Caribbean have the same system. And then, of course, you have a hybrid. Maybe 30% may be coming from public, 30% from social insurance, 20% maybe out of pocket or private insurance or whatever. You have a hybrid of the systems. And this is where you have countries like Barbados, Bahamas, etc., where there's no dominant 50% or more coming from one single source. So when you look across the Caribbean, you're going to find a mix of health financing systems and not one single type of system. Tragedy, however, is that in all the countries, you see that item called direct out-of-pocket payments on average, that is very, very high. Direct out-of-pocket payments mean that you're not getting the coverage that you want in the public sector and you don't have private insurance, so you have to dip into your pocket. And if your pocket is empty or half full, only on some days, you have to do without the care. And that part is a very big part, which is why you have attempts being made for national health insurance, so you don't have to depend upon out-of-pocket payments. Or this is why you have tax systems trying to reorganize and collect a lot more money in taxes, which you can put to the health system so people don't have to be dipping into their pockets in order to pay for care.
Mm-hmm. Professor?
Yes.
Yes, question. The fact that Jamaica has what we could call free health care, doesn't that change anything for us in terms of out-of-pocket spending?
It does to a very big extent, and I'll show you you're jumping ahead of me, but I'll show you a table which shows you how much or what percentage of spending in Jamaica is out of pocket.
Okay.
All right. So you have this mix which takes place, and you can look at the health services, who are the providers, public and private, and who are the financing agencies coming from taxes, private insurance, out of pocket generally. And this is a pattern that you're going to have in most countries in the Caribbean. Here's a table I'm going to tell you about. Again, this is data from the WHO, and 2022 was the last year when they had full data, and it looks like a very crowded table, which it is, but you have the country, you have the second column, which talks about health spending per capita. If you divided all the money that you're spending in the country among the population, then this is on average how much you're spending per person. And we put all of that in US dollars so that we can make it comparable across the countries. Jamaica is spending about $468 per capita compared to St. Kitts, which is spending $1,160, Trinidad and Tobago $1,292, Bahamas $2,341 per capita. As a percentage of GDP, you can see where it is, and you can see Jamaica spends a large percentage, but not an absolute amount. Percentage of GDP is about 7.8%. Guyana spent about 3% of its GDP on health. The WHO target is about 7 to 8%. So you can begin to look at it like that. What is the public share? The public share, and that's my 1, 2, 3, 4th column. What is the public share out of your total or your current health expenditure? In Jamaica, 76% of the money spending on health is coming from public sources. The next 23% generally is coming from private sources, and 1% you get from external grants and aid and support. Other countries, the percentage of public spending is much smaller. Barbados is only 45%. Grenada is 40%, which means that there's a lot more spending being done by the private sector than by the public sector. Now, ministries of health don't like to hear that, because when they're speaking about health in the country, the focus is always, what is the Ministry of Health doing? Or what is the Ministry of Health budget saying? But then there are all these other players in the marketplace, and you can see where they are. So public health spending in your 4th column, you can see the percentage. Private spending, you can see the percentage. Out of pocket, because private has 2 components. Private has an out-of-pocket component and your health insurance, voluntary health insurance component. Across the Caribbean, only about 7% of health spending is coming from private health insurance sources. Jamaica is about 11%, but Jamaica has a smaller percentage also of out-of-pocket spending. That's why overall private spending looks smaller. But other countries like St. Kitts, for example, 43% of total health spending is coming from out-of-pocket sources, and a small percentage out of voluntary or private insurance. External resources, except for St. Lucia and of course Haiti, which get a lot of money from external grants and aid, most of the other Caribbean countries don't depend very much on external grants for their funding. And then the last column is really another way of looking at the money that the Ministry of Health gets, what is called the public health budget. What share of government spending is that? What's the share of the government budget that you're getting? And Jamaica was getting about in 2022, and that was the COVID time, if I remember. You were still now coming out of COVID, so it looks like that. But other countries were getting a smaller share of the budget. Dominica only got 6%, Grenada only got 6% of the budget, St. Kitts 6% of the budget, and Haiti 4% of the budget. On average, about 10 Caribbean countries get about 10% of the health budget. Is that, sorry, the government budget. Is that adequate or not adequate?
What's the WHO recommendation in terms of an indicator like who? What's the aim? At what point does that become catastrophic?
Which the
out of pocket.
Out of pocket?
We're at 11.
Anything above 20%.
Okay, so we're not bad. That was it. We're not so
no, actually.
Is it that we're not doing so bad?
But you see, you have to test that in real life.
True.
You have to go outside. I mean, these are numbers on a sheet, right? Hopefully there's some basis for all of that. I mean, I have some queries whether that is a truthful representation of the Jamaica situation or not, depending on people's spending behavior. Because when you ask a whole lot of people, they still have to be dipping into their pocket to pay for services, even though you have no user fees. And in fact, that's where some of the information we picked up in the survey of living conditions, because the survey of living conditions directly ask persons, how much did you spend on healthcare in the last 4 weeks? So you can pick it out from there. So even though the government may like to think, or the public may like to think that we're doing a wonderful job, no user fees, may very well find that people are dipping into their pocket for a big chunk of spending.
The doctors here who's the patients every day.
Yeah.
We know at the end day, we have to tell the patient, it might be best to just go to this they heard.
Oh.
So it's better if you just go to the MRI. It don't make sense that it's way to happen. So pay for it, and at least we can see the results and we can be step forward. But until we have the results, we can't do anything.
Yeah.
I realize there's a lot of the persons who are admitted in the public hospital when they need these investigations. It's usually a pool of their families. It's not out of their pocket. Some of them call overseas and it's sent in, or they depend on like 3 family members putting together the money. So I wonder if sometimes that is not caught when they're doing these kind of
surveys of spending. Yeah, because they also ask you, how did you pay for it out of your pocket? Did you get help? Did you get support from X or Y source? And that's also one of the items which can be picked up, or which we may be picked up.
Let me understand. You're pointing out the survey of living conditions. So how did we come up with these figures for this?
This is the WHO data. They would have asked the ministries, they would have asked the Ministry of Finance, they would have looked at published data from each one of the countries, and they pulled together this data for about 200 countries around the world.
So would they have onboarded the data that comes out of the survey of living conditions? I mean, I can't imagine Jamaica providing data like this without the input of the planning institute of Jamaica.
No, they wouldn't, because whatever the WHO put together as their first estimate, they run it by you, the country.
Okay.
The problem is many countries don't respond. So what do you think the WHO do? Publish it. If they tell you within 2 months or 3 months, we want you to validate the data, and you did not respond because you're busy doing other things, we're going to publish it.
Oh, yeah.
UNICEF does the same thing. UNDP does the same thing. All of these other agencies, PAHO probably does the same thing. And if they don't get the validation from you, then they use what is called proxy data. What are the comparator countries for you? What are these countries spending for which we have data? And therefore, proxy for you is going to be around that.
So
or we
why
look
are
at
they
your-
telling us that, sir, the document, so we know when to trust and not to trust? I mean,
Yeah, I think I
can
agree.
you make decisions on this if, and maybe or maybe not the data has not been valid?
Yeah.
And I'd add to that because a part of this, because one of the things that came up when I was doing some research for my current research topic is the World Bank's data and how they also look at, in terms of catastrophic household spending. Yes, you have out-of-pocket spending, but how much of that out-of-pocket is coming out of the household income? Is this significantly affecting the household to the extent that they have no money left because they're spending so much on health? And that can impact in so many other areas. So it really leaves a lot to be asked, in terms of the disaggregation of this data. What is it really? What's really informed in this data?
Yeah. And of course, like in all of these surveys and calculations, you have to look at what are the definitions which they're using for each one of these categories. What are the assumptions they are making, and where are they making estimates as against actual data? So all of these have to be part of the deeper analysis of all of these figures. But if you want a quick and dirty run of what is it you're looking like, this is what you do. All right, this is what you do. Because I can tell you, the cost of data collection alone is not an easy one. Not an easy one. So where do you put the money? Data collection or delivering medication for patients? IT guys will say, no, give me the money. You know, we need better systems. The doctor over there working in real life say, what about me? More for you, less for me? That's not right.
If over time.
Priority setting, sorry.
Yeah. No, if over time, like even if it's just one per year, every year they put in the electronic system somewhere.
Yeah.
Over time, when we have all the electronic system here, then it will be easier to collect the data.
Yeah.
And then we can get more accurate data. So in the long run, everything will work out better. Because you don't have to have all these physical persons going around trying to get data.
Yeah.
It goes back to information systems.
At one time, the Ministry of Health used to publish an annual report with all the statistics, data on admissions, discharges, visits, reasons for visits and whatever.
It's still included in the sectoral document that Minister has on. The EPI division, they do our vitals, except perhaps in more recent years, they've been focused on particular things like NCD,
Right.
child health.
Yeah. Okay. Okay.
That's not published.
All right.
It is published. It's online.
Okay. Okay. So the reference to the table is shown in the list of references. So you can look at the WHO information set and see. Right. So we're looking at three main types of financing systems. You can look at the tax-based system, the social health insurance, and private insurance, and you can see what are the main, how you compare them and what you can get from each one of them. Membership, contribution, administration, benefit package, providers of care, provider payments. On the tax-based systems, you have membership is everybody in the population. You know, all residents, all persons who are here, so it's universal membership. Contribution, you contribute according to your ability. This is where the tax system comes in. Administration, it is a public body, which is the Ministry of Health that manages the system, and now with the regional health authorities. The benefit package is a broad package that you have, which is public health, primary, secondary, but not a defined package. You can't go to KPH and tell me, show me what is the list of services that you cover with all of the DRGs and all of these things that you have, all the CPT CPT numbers or whatever it is. You wouldn't get that specification. Sometimes what you find, even with the clinics themselves, is that, you know, if the professional is here, you get it. If the health professional is not here, it may be on the thing, but you don't get it. So how do you have a defined list of services as compared to a private health insurance plan or a social health insurance plan where the benefit package that you're getting is in the booklet or whatever it is they give you, and you have that defined, what it is, how much, how often, all of these kinds of things. So that's a part of the distinction you can begin to look at altogether. Providers of care you have in the tax-based system, government system. Most of them are public providers, but now, as we said, some services have been contracted in the private. And how are you paid? You get an annual budget. You can compare that with a social health insurance system where you want to be universal, make sure everybody, but under the national health insurance system, if you're not a member, you're not a member of the plan, then you're not covered. It is compulsory also because you have contribution according to your ability to pay. Once it's a percentage like NIS or NHT, and that's compulsory, then those who earn more pay more. Those who earn less contribute less. How is it administered? You can have public agencies managing it, or you can have private agencies managing it, as we showed in the systems around the world. Benefit package is a mixed package, primary, secondary, tertiary, and a very well-defined package, very much like what a private health insurance has. Providers, you have contracted public and private providers, because once you have your social health insurance card, you can go to the public sector or the private sector to get the care. Depends on if the providers are contracted. How do they pay the providers? Then you have a mixed method of payment. You don't pay the providers by a budget. That's what the tax system or the ministry system does. You have a mixed payment system. They get fee for service, they get DRGs, they get CPTs, or UCR or whatever it is, the categorization of the services that you have. And with private health insurance, of course, they pick and choose who they want. Mrs. G's, there's no place for you. So we pick and choose, we screen you out or whatever it is that we do, but we pick and choose, and generally they go for formal sector persons only. It's voluntary, even sometimes with a group, it's voluntary in the sense that you choose to join and then you pay the premiums because it's a fixed absolute value of the premium. $200 or $500 or $800, then those who are earning low salaries, the percentage take from you is much higher than if you're earning a high salary. So it is not progressive like the tax system or proportionate like the tax system. It's very regressive because they have a fixed absolute dollar premium. And that's a big distinction. Administration, most of them are private for profit. The benefit package is very well defined. It varies according to what type of plan you want. Basic, major medical, critical illness, executive plan, all of these things. And the providers of care are private and public providers, and they also have mixed payment arrangements. So you can compare them and see where they lie. I have 3 more slides, generally 3 or 4 more slides to run through, and we just focus a bit more on public financing. And there are 2 main aspects of public financing which I want to look at before we close it off. And in part 2 of the session on financing, we'll look at health insurance arrangements. And so public financing, which is what you generally know about, the amount of money you get in health depends on the amount of taxes collected. Government collect taxes from a direct, indirect, earmarked taxes, sugar beverages. So we want you to consume more sugar beverages, so the tax will increase. And if the tax increase, we get more tax take, and then Ministry of Health can get more money. So don't stop purchasing sugary beverages. All right, that's an earmarked tax. Don't stop taking your sip of alcohol when you leave here on a Friday evening. You know, we need the money because health needs the money. In one country that I was working in, the Minister of Health looking at the slide like this, and he told me, so what do you want me to go and tell my people? If you want better health, you have to go and drink more alcohol? I said, well, Minister, if people drink more alcohol, you collect more in taxes. And if you collect more in taxes, more money for you. So I said, you want me to go on the radio and tell the population that? I said, no, sir. No, sir. I wouldn't want you to go and do that.
The same conversation we're having about the terms that it puts the project either amount of money that the government should make. So we're supposed to make 10 billion. Was able Jamaican people decided not to request that.
That'll be money making.
You don't get 10 billion.
Yeah, exactly.
And when you project it, you expect that there will be a decrease in the consumption. I try to figure out how the project is that it will get.
No, they have the Ministry of Finance, I'm sure, would have had their data set. They know what is the consumption.
You might be looking at consumption today.
Sure, of course.
But what if, how do you predict that people are not going to drastically change? And if they drastically change, then you can't project 10 billion.
So you do what is called your scenario or sensitivity analysis. What if it fell by 5%? What if it fell by 10%? What is likely to happen? And if you reach a certain threshold when you do your real life calculation, when you do your gather the data and you see it fell by too much, then you have to make adjustment. All right, so that's part of the data collection that the Ministry of Finance can do. And they can work it out, you know. They know how many bottles or how many cans or how many boxes of whatever drinks are being sold in the country. They have the data. They have the data.
Based on the consumption. No, but what we're saying is that they will say, okay, we expect probably a 30% fall off, and then they reallocation is on a 30% fall.
Yeah, yeah, they can do that. They can do that, and then of course, you know, it is an overtime calculation. In the first year, you try to see whether you've hit the target. Second year, are you way off the target and by how much? And then you begin to make the adjustment. So it's part of that operation. Earmark taxes. Earmark taxes, one which came up very much in the past, is a whole matter of lottery and games. And it was felt that, you know, allow lotteries in the country and let's tax the lottery companies and put some of that money in health. Well, I think that you have lottery games now. What is it? Pick 3, pick 4, big whatever. How many games you have during the course of the day? Right? You know, and you know, and a percentage of that goes to, was it a chase fund or what it was called? And some money comes to health and all of that. But do you think the Minister of Health will go on the radio and tell the population, if you want better health, buy more lottery tickets?
Jamaicans seem to love the gambling, so I don't think he needs to say it.
All right. Public money, of course, also depends upon how much money you're getting in grants from external sources. Depends on the budget that you submit and depends on government priority. If education is a priority or national security is a priority, then that's where the money can be going instead of coming to health. So it depends on priorities. The problems, as you know, in public financing, underfunding, most of the money going to pay workers, little for maintenance, and the other things. The budget structure for a long time was as such that you had to be budgeting by heads. Well, this is money for you know, salaries and compensation. This is money for utilities. This is money for that head. You can't shift them around. I think now that the regions can do a bit more shifting or environment of the funds. But at one time, you couldn't change money like that or shift it around. So you have to go to your finance person and say, I want more money, say, but I don't have that in the budget for you, you know. Your budget is restricted to that. So, but you must have something in somebody else's budget you could take from them and give me. So they don't work like that easily, you know. I have to get permission to do that. So then you could get squeezed in that sense. And so the whole matter, the rigidity of the structure of the budget could be playing a role in how you're dealing with all of these other supplies, etc., that you need to be providing for in the health system. Inadequate resources for the public service restrictions, no incentives for innovation. At KPH, you could be doing new things, wonderful things, saving a lot of money for the system, but you don't want to get extra money in your budget for that. Innovation in the private sector, the more innovative they are, the higher the fees they can charge. I bring in this new machine, I offer this new test over here, or all of these things, or I put in a new AC system, Wi-Fi is all inside of there, I can put a little charge on that. Amenities, but innovations, the public system doesn't get any additional budget for innovation, so there's no incentive in a way to do that. And then there's some ongoing waste which you look at. This one over here, the whole matter of user fees. I know we abolished user fees in 2008. But in other countries where you still have fees, then the reasons you raise additional revenue, you organize the fees, you can deter unnecessary demand. If services are free, people might over-demand. You can target utilization to certain services, like you can have zero cost for antenatal and maternity, for immunization, or low fees in the health center, while you have higher fees at the hospital for the same services. So in a way, you sort of try to redirect patients to the thing. And then it enhances cost awareness by health workers, many of whom might sometimes think, it's a public thing, man, it's a government thing. You don't have to worry about the cost. You have to be thinking about the cost. You could have a very good system in place, but if the government policy is nobody should be turned away because they can't pay, then people know how to beat the system. They know how to beat the system. They can come dressed in all their old rags and old clothes and say, see how poor I am. No fees for me, but you know generally that they can't pay, which is why when the fees were there in place in the Northeast Regional Health Authority, I remember the CEO of a particular hospital called St. Anne's Bay Hospital. She knew everybody in the community. So you can't come with so hard luck story and say that you can't pay. She know you. That's as well. They were very good at collection. Very good at collection. Like that. Right. Fees can work, you know. The thing of fees can work. And that's why you can look at two sides of the fees. If you operate it right, you can get improved health for the population. You don't operate it right, you're going to get worse health in the population. You must have a good exemption system for the poor, for certain categories of services. You have to use the money to improve the, make services more available, have the drugs, have the nurses, have the other professionals there, have the lab tests available. You can improve quality, you can get increased access, increase utilization, and improve health. Or you don't do it right, a poor exemption system, still have service coverage, shortage, etc. People delay seeking care, access problems, decrease utilization, and you could end up with poor health, depending on how you want to manage and design the system. Can you do better? Well, some countries can do better, and they have put things in place for a more efficient user fee system. Adjust the fees regularly depending on inflation. Whoever is collecting the fees should keep the fees. Don't send it back to the government or the public Ministry of Finance or the consolidated fund. Keep the fees. Improve your billing and collection system. More cashiers, no cashier going for lunch, or no time when they lunch. Or in the evening times when most cashiers would have gone away from work according to public service regulations, then that's the time many patients might be coming in, and you're going to be losing out on that. Collect payments by different arrangements, not just cash only. Have some prepayment plans like down payment for elective surgery, installment payments. Improve admission, billing, and discharge system. Sometimes patient gets discharged by the doctor and they're going through that door, but the entrance to the hospital was over there. They never passed through by the admissions office. You can't have that. Every person who is coming into the system must have an admission number or admission. They must be registered. Every time you leave your discharge, you should be coming through this door over here. This is the way out, so we can know, did you pay or did you not pay? And that's how you can begin to look at improve your admission, your billing, and your discharge system. Sensitize staff so you don't have some workers telling persons don't pay. And then improve your exemptions and your targeting. In the public, sometimes we have to look at what is called results-based financing, and this is one which I don't want to look at closely over here too much. We're going to pick this up when you're looking at efficiency. Results-based financing literally means we don't pay you because you just show up to work. We don't pay you because you are qualified. We pay you because of your performance, because you are meeting certain targets, outcome indicators, uptake of services, compliance by patients, quality of care, abiding by the protocols. We do surveys of patients to find out whether patients are satisfied with the service that they're getting. We look at incidence of illness in the country, intermediate how long people have to wait for care, and all of these things could be part of your indicators that you're going to use. And depending on how you're performing, a percentage of your money could be coming in performance-based type of payments, as against just giving you a budget. Belize, for example, and some of the systems over there have been doing that. And we can look at the Belize experience in this since 2001 in their national health insurance program. They have quality of care protocols. So if you're treating a diabetic, what is the range of services that is supposed to be provided to a diabetic? You have to tip off all these boxes. And we're going to ask the patients whether they're satisfied or you actually get it done. So you're just not taking the word of the health facility. Administrative arrangements, you have good records, you have complaints mechanism, you comply with equipment functionality, etc. You have continuous education, and they organize a system that will give you 70% of the money up front, and you withhold 30%. If you meet all the targets, you get the next 30%. You didn't meet the targets, we'll have to talk about how we withhold some money from you, or we might give you a bonus. And this is all part of what you can look at on the results-based financing. Yes.
How much of that is placed on the individuals working at the different facilities?
Yeah, that's one of the big things, because remember, I think a few years ago in Jamaica, you were talking about paying teachers according to their performance. How are you going to measure performance of teachers? How are you going to measure performance of public sector workers? How are you going to measure performance of health workers? So that's a big factor. That's why I said there has to be ongoing measures. There has to be all of these discussions with the staff, training of determination of what exactly can be done, what exactly can be performance, have indicators for and what you cannot, and how you balance the two. Because there are some indicators you can't do. If you say this is my department, it is, for example, orthopedic department, or probably it's the neurology department, or it is the health promotion department. There's some things we can set targets, and we meet the target, we say, good. We can give you some performance-related payment for these. And in much of this, you need to get it evaluated to see how it's working. And you can't ask the agency itself or the hospital itself to evaluate itself. You might get the wrong answers. So these are all some of the things which you begin to look at on the results base.
Not to believe by circle, I know you're almost finished, but I guess your evaluation can only be as good as your instrument and your environment, because you can't be evaluating physician performance on patient outcomes, scans done, times to the patient. So the clinic is full, one doctor is there, 30 people waiting, MRI, no CT, no ultrasound, no nurse, don't come to work, and you're evaluating. It doesn't work like that. It's going to be entirely circumstantial.
You clearly. So that's what the ongoing discussions. It doesn't mean it cannot be done. Right. There are some things you can start with. Again, it can be done progressively. So you have some easy, what they call it, low-hanging fruit that you can begin to touch on, and then over time you can begin to see. But more and more, it's going to become part of your compensation arrangements. You see, once the IMF is looking over the budgets of Ministry of Finance, and they're telling the government of Jamaica already, you're spending too much on public service salaries. You need to find a way to reduce that. Too much money in the budget is going to salaries. Now we begin to look at
the parliamentarian.
All right. Somebody else, not me. Yeah, somebody else, not me. All right. The last slide is really your checklist. What are the 6 key things we said? Health, finance, and one of the essential building blocks, 3 major components. All countries have major challenges. Universal coverage says these things. Globally, these are mixed financing systems, out-of-pocket payment large, tax-based system, depend on government revenue, depend on issues like underfunding, etc. User fee systems, which are there in place, and results-based financing, how that can be tied to protocols, designs, but there are challenges with that. And that's, in summary, is what we have been looking at. So you have your reading list at the top to look look at some of these, and that's what we wanted to do. Okay, online, anybody want to raise anything? Because that's the session.
Thank you.
Professor?
Okay, no, all right. Yes.
Yes, did
Simone?
you tell us when the mini research is due? Did you give us a date?
Yeah, that's going to be in May, about the middle of May.
Oh, there's no exact date.
I'm going to discuss again with Dr. Thompson, and we'll send you some guidelines and the time frames and all of these things. But it's going to be when I return in May, definitely
no
around the middle of May.
All right, no problem. Thanks.
Yeah.
Those are free, sir.
Which?
The papers to read. Now, some papers they can't access so easy online.
No, all of them. I mean, the OECD is a very big organization. WHO, World Bank, are big organizations. You can just Google them and Google the particular paper you're looking for, and you should get it. The other things, like the paper by Lauter, it's a book available in the library. Same thing with the one with public health in the Caribbean. In fact, Professor Peter Figueroa is one of the authors of that book. He may have copies upstairs. You can think so. And the others are World Bank publications, etc. So you can get those, Google online and see that you get them. Right? The WHO data is online as well.
OECD, I think, has five categories they use to evaluate. One of you can ask when I have the question structure.
All right, sure. Okay. Okay. All right. Well, thanks much. I will talk to you online, and then we will see you again in May.
Yes. Thanks, Prof.
Right. All right. Good. Stop share.
Thank you. Take care.
Okay. Yes. All right.
Thank you so much. Have a good weekend.
Yes. Okay. Is anybody driving down to Ligani?
I'm taking you, sir.
You taking me? You are.
So, can I get home?
No, I just want to reach Ligani.
That's Ligani, all right, no?
Yeah, because I have to meet a few people in one of the restaurants over there. They decided to welcome me and say goodbye to me. So, so let me just do that. Thank you much. Because we are going, what is it? Sea Deck Restaurant, just on Barbican Road.
Oh, no, not the.
Oh, that's not what you're talking about.
No, you say.
Because they say we're not seeing you.
Yes, sir.
They say we're not seeing you till May. Oh.
Oh, you went on person?
Maybe if it's in our place to ask. If it's not in our place to ask, that's okay.
I have to go back home.
Oh.
Okay.
Yeah. That's the only reason.
Oh, I thought you're just leaving us.
I'm not working on the staff of University of the West.
Oh, okay. All right, thank you.
Okay then. Yeah, all right.
Bye.
So the next couple of sessions, I will continue those. That's right. See you back in May. Okay, good. All right.
That's right.